Yeah, good morning, everybody. I wish you happy Diwali at the outset. And I, on behalf of Indian Medical Association Mumbai branch, welcome you all for the webinar on the occasion of World Diabetes Day. Now I hand over the proceedings to Dr. Vijay Punjabi sir, the chairman for this particular webinar. Thank you.
Good morning, everyone. Let me first of all wish you a very happy Diwali and a prosperous new year. Today is the World Diabetes Day 2020, and the theme for the World Diabetes Day is the nurse and diabetes, because nurse and the paramedical play a very important role in controlling the diabetes and helping the medical people. And today we celebrate the World Diabetes Day usually every year on 14th of November, because it happens to be the birthday of Sir Frederick Banting, who co-discovered insulin along with Charles Banting in 1922. As you all are well aware that India is the capital of diabetes, having 77 million people with diabetes out of the 460 million diabetics from the whole of world. That means 1% of every 6 diabetic in the world is from India. And the prevalence in our country is about 8.9%, according to the International Federation of Diabetes. If the diabetes unmonitored and uncontrolled, then the prevalence of diabetes leads to the various complications which affect the target organs like heart, kidney, eyes, nerves, and vessels. And the diabetes creates a problem for various other diseases. So diabetes with tuberculosis, diabetes with HIV, diabetes with renal disease will create more problem. But now, friends, as you are aware, today we are in the pandemic of COVID-19, and it has been established that the diabetics are at the higher risk of COVID-19. So at this point of time, we are focusing on the renewed management of diabetes and COVID-19. So today, we are having various specialists to enlighten us on this field. So at this point, I hand over the mic to Dr. Sujatu Nisa for her presidential address.
Thank you, Dr. Punjabi, sir. Good morning, friends. At the outset, I would like to wish everybody a very happy Diwali and a very happy New Year to all. Thank you, everybody, for joining us for the webinar on diabetes on this Diwali day. This year, IMA HQ has given the directives to all the branches to have an ongoing program on prevention of diabetes blindness. All the details has been given by Dr. Punjabi that the theme this year is to the nurse and the diabetes, because as diabetes is coming as a in the global pandemic and it is become like an epidemic, we need to have healthcare workers also trained in how to handle the care, educational and awareness for the diabetic patients. And basically, all diabetic patients should take care of controlling diabetes through diet, exercise, and medication. But lifestyle changes plays a major role into the care of diabetes. And I would now thank everybody for joining, and I would hand over the mic to the chairman of this program, Dr. Vijay Punjabi, to start the webinar.
So first speaker today we are having is Dr. Mangesh Patil. He will be talking on nephron sparing surgery in diabetes, and I invite Dr. Pragji Vaza to introduce him.
It gives me great pleasure to introduce Dr. Mangesh Patil. He's a consultant urologist and robotic neurosurgeon, uro-oncosurgeon at Sir H.N. Reliance Hospital. He pursued his DNB from PD Hinduja Hospital after completing his MS General Surgery from GMCH Nagpur. He has completed his urology training at the Hinduja Hospital and has the distinction of conducting over 4,000 urological procedures during his training. He then went to Roswell Park Cancer Institute for his robotic surgery training. A pioneer in the field of robotic urological surgery, Dr. Mangesh is one of the few surgeons in India who has completed over 560 independent robotic surgeries, including prostatectomies, nephrectomies, cystectomies, and radial hysterectomies. He also specializes in laser TURPs and renal transplantation. Dr. Patil has received training on the Da Vinci robotic surgery technique from renowned surgeon Dr. Khurshid Guru from New York. He has received numerous awards for his work, including the Asia Pacific International Award for Health Excellence in 2014. He is a respected member of the Robotic Surgery Training for Urological Cancers, Urological Society of India, and Mumbai Urological Society. I give a warm welcome to Dr. Mangesh Patil to give his talk.
Thank you, sir. Thank you for such a kind introduction. And I really thank IMA for giving me an opportunity. Also, Sir H.N. Reliance Foundation Hospital for making the platform available for me. So, myself, Dr. Mangesh Patil. I work as a consultant urologist at Sir H.N. Reliance Foundation Hospital and few others nearby. So I will be talking about nephron preserving surgeries in diabetes. So I'll just start the screen share. I hope I am audible. So today I'll be talking about nephron preserving surgery in diabetes. So in view of the World Diabetes Day today and the number of cases, incidence is going up through our society and throughout the world, awareness about the diabetes and urological problems is very important, and it is probably amongst you all are seeing a lot of patients with diabetes and urinary problems. So most of them will be urinary infections, prostate enlargements, pyelonephritis, but there is one entity which is again common but needs some specialist intervention. So that is known as renal tumors in diabetes. And as the diabetes duration increases, the creatinine goes up. The need for preserving each and every nephron is essential in every patient to basically avoid the dialysis and its complication. So I'll start my talk about nephron preserving surgeries in diabetes. So my talk basically will highlight problems of diabetes mellitus, the problems of renal tumors, and how a renal tumor patient with diabetes is to be managed ideally. So initially I'll brief about the diabetes and its pathophysiology, how it affects the kidneys. So basically diabetes is a long standing or long duration chronic process where the kidneys gradually get affected and leads to rise in the creatinine. Now, at the onset, basically the kidneys have increased blood flow, which may cause strain on the glomeruli and deposition of extra materials, mucopolysaccharides and other materials in the glomeruli, which increases the force of blood moving through the kidneys, may lead to hypertension systemically. Now this stress on the glomeruli, which is gradual but progressive and leads to scarring of the glomeruli, and eventually the ability to filter blood is affected. Now other factors in diabetes are hereditary, diet, lifestyle, and other medical comorbidities like hypertension, they also add to the damage to the kidney. Now, basically, the longer the diabetes, the more the effect on the kidneys. So higher level of blood sugars will cause more damage to the kidneys, and again it will it will start getting filtered through the nephrons. Now over time what happens is the ability to filter blood is reduced. So the most important protein in the blood, albumin, that starts getting excreted. So maybe proteinuria is the first sign or a finding in diabetes, and a subtle proteinuria needs to be picked up and immediately treated. Now with this hypoproteinemia and damage to the kidneys, it starts a process of CKD. Now initially the kidneys can filter the blood, but then as the CKD progresses, more and more protein starts leaking, and it starts affecting the person in the way that they start losing or holding salts, electrolyte imbalances, the toxic products are retained in the blood pressure rises, and of course extra fluid is deposited in the third space, edema feet and pulmonary edema. So ultimately what happens is a certain stage occurs where the creatinine goes significantly up, and now the healthcare provider, the practitioner or the specialist, has a challenge of treating this kidney failure. Now there are two ways. One, the prevention is the best way, but if the creatinine goes up more than 4 or 5, the patient may need either a hemodialysis or a peritoneal dialysis or a kidney transplantation. Not all patients of diabetes are fit for kidney transplant because of age and because of comorbidities. So best way is to prevent. If it happens, sometimes they may need dialysis. So how do we prevent? Medically, yes, we can control diabetes, blood pressure, but in case a patient develops a condition like a kidney tumor, now what are the ways how we can preserve the kidney function? So that was brief about the diabetes affecting kidneys. Something about renal tumor. Typically, renal cell carcinomas, most common kidney tumor, which affects 2 to 3% of tumors in adults. Most of them are idiopathic, but there is an association with smoking, hypertension, and components of metabolic syndrome, hypercholesterolemia, that has some association with occurrence of renal cell carcinomas. Diabetes mellitus is one of the consequence of metabolic syndrome as well, and it is very commonly seen in renal cell carcinoma patient. Basically, the diabetes and renal cell carcinoma together form a very dangerous combination, and the rapid deterioration in patient's general condition can happen. It is acting like a paraneoplastic syndrome as well. Hyperinsulinemia and hyperglycemia are one of the carcinogenic factors, and tyrosine kinase inhibitors are known to reduce blood sugar. Hypoglycemia is seen in those patients. Now, basically, the link between renal cell carcinoma and diabetes is two ways: the incidence and the prognosis. The incidence is high, and the prognosis is also bad. Now, the two ways how we can assess the results are standardized incidence ratio and standardized mortality ratio. I won't go in details, but overall the prognosis in patients with renal cell carcinoma and diabetes is poor. The incidence of kidney tumors in diabetes ranges between 5 to 40%, but in countries like Italy, it is 9.1%, and USA, it is almost 25%. So in females, again, the incidence of diabetes with renal cell carcinoma is higher as compared to men. Diabetes with renal cell carcinoma is usually seen in older men, asymptomatic patients. Clear cell carcinoma is the most common histopathology, and they are usually smaller because of the repeated scanning. The mortality is doubtful whether it increases the mortality, but yes, the morbidities definitely increase with diabetes. Now, how do we predict? Is usually the HbA1c and routine check of the sugars, and diabetes is known to be an independent predictor of the disease progression. It definitely increases, diabetes definitely increases the risk of malignancy recurrence, and 5-year relapse-free survival is definitely less in diabetic patients. Again, one of the important factor is obesity, and it is responsible for quite a lot of insulin resistance, which again makes the diabetes uncontrolled. So abdominal obesity or central obesity needs to be controlled, and lifestyle modification are important. Diabetes is sometimes seen in renal cell carcinoma patient as a paraneoplastic syndrome as well. So there are few cases reported. One of the case was a case of operated renal tumor around 10 years back, starts having diabetes and it is uncontrolled. So investigation showed recurrence of renal cell carcinoma, and treatment of renal cell carcinoma had shown control of the blood sugars. So that was one case. Second case was a known case of RCC, post-surgery 9 years, patient starts having polydipsia, polyphagia, diagnosed to have diabetes and with recurrence. So they immediately respond to tyrosine kinase inhibitors, and the diabetes also is almost completely controlled. So these are the possible reasons paraneoplastic syndrome. Again, the treatment for renal cell carcinomas, metastatic ones like pazopanib or TKIs, tyrosine kinase inhibitors, have shown to reduce the blood sugar. So there is definitely an association between diabetes and renal tumors, and it has responded to the TKIs. Again, what are the level things happening in diabetes is usually the hyperglycemia that causes rise in incidence of diabetes and malignancies. Basically, protein kinase hyperactivation is one of the pathway, and of course, insulin resistance through insulin growth factors. They are the reasons for renal cell carcinomas in diabetes. Now, usually a patient with localized renal cell carcinoma in diabetes, they are usually slow growing tumors, and any aggressive treatment, curative intent, is usually gives the patient a benefit, and which can avoid complications of metastasis or the prognosis. So basically, T1 and T2, they are the early stages where the tumor is located inside the kidney. We should aggressively treat. If the patient is fit for surgery, controlled diabetes, the patient should be offered a curative surgery. And for any localized renal malignancies, the best treatment recommended is surgery. And if we don't aggressively treat, they usually land up with either metastasis or CKD in those who have bilateral tumors. Any diabetic patients need to be treated with thinking of possibility of CKD in the future as well. Historically, till long time, for long time, the partial nephrectomy was not offered as a standard of care for most of the tumors. There were few indications like solitary kidney, poor renal function, bilateral tumors. They were the indications accepted, but not as a standard of care in every patient. Even if the patient doesn't have a medical comorbidity, we still can advise a partial nephrectomy. The reason is the metabolic syndromes or the CKD chances with unilateral nephrectomy or a partial nephrectomy are still high in the opposite kidney. So all the efforts were directed to do a partial nephrectomy. Initially, an open partial nephrectomy was usually done because of unavailability of the technology. But as the time went, the effort to reduce the morbidity of open surgeries, the surgeon devised laparoscopic surgeries, laparoscopic partial nephrectomies. But again, laparoscopic partial nephrectomy had some complications which were very dangerous for patients' life. Patients have had mortalities. So the improvement in laparoscopy is nowadays used as a robotic assisted partial nephrectomy. It has emerged as a preferred technique. So there are 3 ways we can do a nephron sparing surgery. Every nephron we have to preserve. So that is also known as partial nephrectomy. And there are three ways: open, laparoscopic, and robotic technology. Now, basically, the advantage why the evolution has happened is partial nephrectomy is a very dynamic surgery. Almost 20% of blood cardiac output is given to the kidney during every cardiac cycle. And if the surgery doesn't happen quickly, there's a lot of blood loss, lot of complications, and the patient land up in ICUs, and they usually need blood transfusions. In robotic surgery, the accuracy and precision is so much that all the ischemic damage is prevented, and the patients usually do well with the robotic instruments. The distinct advantages of robotic surgery are the three-dimensional vision and EndoWrist instruments. I'll explain in detail as the slides come. But the optimum treatment, optimum selection of candidates for robotic surgery is, I will say, as an individual, every renal tumor we should consider robotic surgery because of less morbidity, accuracy, and more number of nephrons preserved. There is no ideal tumor or not ideal tumor. All, even difficult hilar tumors, can be treated with robotic surgery. There are certain indications of nephron sparing surgery, like bilateral synchronous tumors, or tumor in the solitary kidney, or conditions like von Hippel-Lindau syndrome, where the multiple tumors can occur at different times and the patient will eventually lose kidney. Again, the indications have expanded to CKD and diabetes hypertension because the possibility of CKD in the future. So a partial nephrectomy, that too a robotic surgery if possible, is the preferred method. Another important thing which happens in partial nephrectomy is whenever we are doing a surgery on kidney, we have to stop the blood supply, and that causes ischemic damage to the kidney. Now, in open surgery, the ice application around the kidney has reduced the ischemia. But in laparoscopy and robotic, it is not possible. So all the laparoscopy and robotics are done in a warm ischemia. And that's why we have to be as quick as possible. Normally, the time given is around 15 to 20 minutes. So earlier we declamp the kidney, faster the kidney recovers. The other fear in mind is the recurrence of cancer. That probably was the reason for why radical nephrectomy was preferred. But nowadays it is proven the recurrence in partial and radical nephrectomy are same, or in fact better with partial nephrectomy, and quality of life is definitely better. Oncologically similar output, and it all depends on the renal scoring, the selection of case, the complexity of the case. So just to make you aware, there is a scoring system that is known as renal scoring, RENAL, and the higher the score, the complex is the case, and the more the chance of robotic surgery being successful in them. So the surgery from open has evolved to laparoscopy, has evolved to robotic surgery. So let's go one by one. In open surgery, we take a cut in the flank. The cut will be in the flank. We dissect the kidney. We put ice around the kidney, cool the kidney, clamp the kidney, and remove the tumor. Now, after removal, there will be a raw area which will be sutured, with absorbable sutures, and then the closure of the anastomosis. Now, closure of the incision. Now, what happens is a lot of pain, infections, bleeding has put open nephrectomy, partial nephrectomy as a second option. Then came laparoscopy. Now, laparoscopy has advantage of less pain. The surgery can be done quite accurately, but not really very accurately. The lot of nephron tissue was lost, and that's why the option of robotic surgery came. Now, in robotic surgery, the advantages over the laparoscopy are three-dimensional vision, the motion scaling, the wrist articulation, tremor filtration. The senior the surgeon, the more the tremors are seen. So it is better if we use robot. The tremors will get filtered, and that gives a better result. Magnification is high, And of course, junior doctors can be trained. I'll show one video where the robot, how it works. The advantages to the patient are definitely the reach is different, the smallest of the incision, less blood loss, less pain, faster recovery, and they resume early. Any advantages to the surgeon? Yes, magnified vision, better control. So longevity of the surgeon also goes up. What happens is earlier I used to do one surgery a day or two surgeries a day. With the robot, we can do definitely more number of complex surgeries and without getting fatigued. So far, we have almost completed 556, more than 556 actually, and out of which 36 surgeries are partial nephrectomies. And the number is going up as compared to radical nephrectomy, and probably reason is more complex surgeries can be done. That's the picture of EndoWrist instruments. You can see how the instruments move inside the abdomen, and varied number of or varied direction of movements like wrist and better than wrist can be seen at the hinge of the wrist of the instrument. That's the picture of robot in action, the actual robot over the patient's body, and that's the diagram how we place on the patient's body. Let's see a video how the robot actually works. You can see this is the console, that's the patient side card, and that's the vision card. Now, assistant or a nurse is required to change the instruments. The surgeon is physically there in the theater. So anytime, any situations, the surgeon can jump on the operation theater, immediately scrubbed in and do the surgery open ways. That's a binocular through which the surgeon can see a three-dimensional picture. It's a very high definition picture, so minutest capillaries can be seen, and same movements done on the joysticks on the console, they are copied externally. You can see the movements of the instruments. The distinct advantage for junior doctors or assistant doctors who are training is that the main surgeon can hand over the controls to the junior doctor, and junior doctor can do the surgeries. Any situations where the junior doctor is not doing well, the main surgeon can take over the controls and do the surgeries without complications. We can see the movements of the instruments out of the body, and the finer movements are seen inside the body as well. So that was a quick video. So how an animation will be a better thing to just quickly show you how the partial nephrectomy is done. So that's the three-dimensional picture of a human body with the kidneys lying in the lumbar region. The main vessels, aorta and IVC, they are the important vital structures, because any bleeding, any injury to these structures can be a torrential bleeding and can cause death of the patient on table as well. So whenever we dissect the tumor, we mark the tumor with marker or the cautery. Most important situation is clamping of the vessels, because unless we clamp, we will not be able to cut the kidney. It will bleed like anything if we cut a vascular kidney. So the blood supply has to be stopped temporarily. Once the tumor is dissected from all the sides, we pick up the tumor, keep it on one side of the kidney, and then rest of the thing is sutured with absorbable suture. Now this step is very important, and that's why robotic surgery is important, because in laparoscopy these sutures are always weak and there is always chance of bleeding from the parenchyma, re-explorations and complications. So robotic surgery definitely has an advantage over laparoscopy. A quick surgery which was done by me at one of the hospital, and I will show you. This was a 30-year female. She was completely asymptomatic, incidentally detected tumor, and that's a right-sided tumor. You can see the vital structures like aorta, the pulsations of the pulsations in the IVC on the right side, and any small injury also can cause torrential bleeding. That's the liver which can be seen reflected upwards, and the kidney being dissected. All the minute test of the blood vessels are seen clearly, so the blood loss is absolutely minimum. Normally in a radical nephrectomy open ways, the blood loss is around 300 to 500 ml or sometimes more also. But in robotic surgery, in last 100 robotic surgery, I don't remember I have transfused blood to any of the patient for surgical reasons. That's the kidney being dissected, and it is so precise and accurate. Whatever blood you are seeing is hardly half a teaspoon or something, which is like 5 to 10 ml of blood loss. The ureter being dissected, the renal artery, you can see the movements of the hands so swiftly going around the vessels without any scare. That's the renal artery with pulsations. We sling the renal artery so that in any dire situations we should be able to control the bleeding, or we can tie the renal artery in worse situations. We take a control over the renal vein as well, so that all the vessels, hilum is under control. No, in no situations we want any mortality on table. So we take all the precautions, control on the table. That's the tumor seen on the kidney surface. Relatively easy case because exophytic tumors are easily seen on the kidney surface. They are easy to demarcate and easy to suture. Again, this is an anterior tumor. Anterior tumors are easy to treat than posterior tumor, because posteriorly we have to dissect, flip the kidney completely, so that we have to go behind, and then only we start cutting on the parenchyma. That's how you can see the swift movement of the instrument. We have gone across all over the side of the kidney, the tumor, and once this thing is done, we try to avoid dissecting over the tumor, so that the chance of spillage of the tumor or handling of the tumor is less. I usually prefer to mark the incision before clamping the arteries. We have not clamped the artery. We just mark it on the surface and make a plan how we are going to, or where we are going to cut. So that's the kidney surface being marked. You can see hardly any blood loss so far. Even after cutting the kidney, you might see a little bit blood, but that will be like 2 to 3 teaspoons or something. It's a so magnified view that sometimes it may apparently appear a little bit of bloody, but trust me, it is 3 to 5 teaspoons in on an average in any partial nephrectomy. So these are the bulldog clamps. We place them in the peritoneum so that we have an access immediately, and then once the bulldog clamps are ready, we apply them on the renal artery first, and then renal vein as a second bulldog, so that all the blood supply in and out is stopped, and then we start cutting on the surface. Without clamping, if we try to do this, it will be at least a liter of blood loss. So with clamps, you can see hardly any bleeding in the tumor area, and the margins are very clear, the glistening surface, and nowadays 1 or 2 layer margin is also good enough. Pathologically, it doesn't change any oncological outcome. The swift movement of the instrument is really appreciable, and it is really difficult to do these things laparoscopically, or maybe a learning curve is quite long with laparoscopically. So the medullary sutures are taken, so that's the hemostatic suture, and once this is taken, we apply clips on the suture so that it gives a good tamponade effect. Cortical sutures are usually interrupted sutures, and we put a Surgicel bolster so that whatever possible bleeding, that will be taken care by the bolster pressure and the fibrin material in the bolster. That's the surgical bolster. It's an absorbable material, and we leave it. It just forms a fibrin glue on the surface and reduces the chance of bleeding post-operatively. Once the bolster is in, we tighten the sutures so that we don't want any complication. The most common complication is bleeding from the tumor bed or the renal bed, and the treatment for that is either angiography or re-exploration and doing a nephrectomy. So this is most important step to do the suturing, cortical suturing, and once that is done, we open the renal vein first, let the passive perfusion happen, no bleeding, we open the renal artery, we see for any active bleeding, release the control over the vessels. So that was a quick video of and that's the tumor. This is a plastic bag which is impermeable to cancer cells, and we make sure that we don't leave the tumor in the peritoneum. Once the hemostasis is confirmed, we close the gerotas as much as possible so that any bleeding with the tamponade, again, it will be under control. A drain is kept, and that's the tumor of around 3.54 centimeter. So that was a quick video. And just to conclude my talk, the more the utilization of nephron sparing surgery with surgeons, definitely robotic surgery is a way to go, and definitely it will help in reducing the chance of CKD. It is essential to preserve the nephrons to delay the initiation of dialysis in the diabetic patients. So I end my talk. Thank you so much. Any questions, I'll be happy to answer. Thank you so much.
Hello. Any one or two questions we can ask? Anybody who wants any question, please type on the chat or raise your hand.
Sir, I can see one question. Dr. Rajan Patel has a question about the difference in cost of laparoscopy versus robotic in nephrectomy. Sir, laparoscopy is definitely cheaper than robotic surgery, but trust me, sir, robotic surgery gives the much better results, and definitely a peaceful sleep to the patient as well as to the surgeon. Results are definitely better with robotic surgery. Agreed, financially it strains a little bit to the patient. It is around 1.5 lakh rupees over and above laparoscopy, but it's worth spending those if the patient is affording. Nowadays, the insurance companies are also accepting the robotic surgery. So that will definitely add to the number of robotic surgeries, and the results definitely matter. Thank you so much.
Okay. So I think since we are running short of time, I thank Dr. Patil for the excellent presentation, for the telling us the transition from open surgery to laparotic to robotic. And I'm sure that people would have got a lot of knowledge, and more and more people will opt for robotic surgery. Thank you, sir.
Thank you. Thank you.
So our next speaker is Dr. Bipen Chandra Bhamre. He will be talking on coronary bypass and diabetes mellitus, the recent trend. And to introduce him, I request Dr. Jitesh Mehta.
Yes,
Dr.
sir.
Jitesh Mehta.
Yes, sir. Thank you. Friends, Dr. Bipin Chandra Bhamre is a consultant cardiothoracic surgeon at Sir H.N. Reliance Foundation Hospital and Research Center. He has done his MBBS, MS, MCH, cardiovascular and thoracic surgery and MD from USA. He has been trained under one of the foremost heart surgeons, Dr. Denton Cooley, at Texas Heart Institute, Houston, Texas, USA. He has also completed fellowship in minimally invasive cardiac surgery from Stuttgart, Germany. He has received a gold medal in surgery from University of Pune in 2005. He was recipient of the Acharya Sushruta Sadbhavana Award for medical services in 2009. He has a special expertise in coronary artery bypass grafting and valve repair and heart replacement surgery. Today, Dr. Bhamre will be speaking on coronary bypass and diabetes mellitus recent trends. I invite Dr. Bhamre.
Thank you, Dr. Mehta, for such a wonderful introduction. And I thank Dr. Attar Madam and IMA for giving this me opportunity to speak today on World Diabetes Day. Okay. So prior joining Sir H.N. Reliance Foundation Hospital, I used to work with the one and only Dr. Denton Cooley, who has popularized this operation of bypass surgery, and my mentor, Dr. David Ott. So today we will be speaking. I will be speaking about coronary artery bypass grafting, particularly with diabetic patients. So as we know that diabetes is a risk factor for cardiovascular disease, and it affects the blood vessels, endothelium of the blood vessels. And what we have seen as a cardiac surgeons, that the patients who are diabetic, they have very small blood vessels, like 1.5 millimeter, 1.25 millimeter. And these patients also we miss clinically sometimes, as they don't have classical symptoms of angina. So we must be very careful if we are having long-standing diabetes of 10 years, 20 years. And these patients may not come as angina pain to our clinics. So diabetes is known to cause inflammation of the endothelium by various mediators, and this incites the damage to the endothelium. Normally, if we see our heart utilizes free fatty acids for its normal requirement, but when there is an ischemia or inflammation, it utilizes glucose. And if there is a hyperglycemia, not in, only in the heart circulation, but also the brain circulation, these microvessels, they get blocked because of this hyperglycemia. So, and another additional problems that we must screen for in these diabetic patients, particularly with CABG. There are other increased associated comorbidities like chronic renal failure. Dr. Mangesh had already elaborated on that. Then these patients are more having congestive heart failure because of the diastolic dysfunction. These patients will have peripheral vascular disease, as it affects all the blood vessel circulations, including the cerebrovascular disease. So in particular, if the patient is having a diabetes, and if the patient has a proximal LAD lesion, which is starting from the origin of the LAD, these patients should undergo bypass surgery, because the long-term results of these stents are not good in such patients, and they need repeated revascularization after doing one stent, then again in few years. And you see after few years, the patient within 4 to 5 years gets around 4 to 5 stents, and later on after that he landed into CABG surgery. So diabetes is a indication that patient must undergo a bypass surgery. So when we say a proximal LAD, means what is the portion of the LAD which is prior to this septal branch. This first septal branch, if you see, this is suppose the origin of the LAD, and then the disease should be proximal to this. If it goes beyond this, then it is called as mid LAD, and if it goes beyond the first diagonal, then it is called as mid to distal LAD. So we should be careful in choosing treatment for such patients. And as I told you, if there is associated LV dysfunction, left main coronary artery disease, because what we have seen, even if we stent the left mains, these patients actually are more prone for restenosis. So if we see the history of the bypass surgery, when it was introduced in Cleveland Clinic in 1967, all veins were used. Then a Russian surgeon introduced the internal mammary artery into clinical practice. And that paper was in 1964 or 65, prior to Cleveland Clinic's paper. But he implanted the internal mammary artery on the myocardium directly, because the knowledge that time was not that much that we should implant the artery or anastomose artery to the coronary vessel. But later on, Cleveland Clinic published a paper in 1984 that if you are using one internal mammary artery, the survival of the patient and the survival of the graft also is much better, almost reaching to 92% at 10 years. That paper had a case study of 10 years. Later on, as the experience of surgical community grew, and the radial artery was introduced by Dr. Carpenter group in Paris, and this was introduced in about 1973. So there were a lot of studies which compared whether we should use a second graft as a radial artery or right internal mammary artery, as the Lima goes to LAD. So there, and now the guidelines of 2016 has clearly mentioned that right internal mammary artery has proven better than radial artery, because the right internal mammary artery doesn't have much muscle in it, so it is less prone for spasm. And if you use a radial artery, when the coronary artery stenosis is less than 90%, the chances of flow through the radial artery is very less. So even if the patient is diabetes, almost half of our patients undergoing bypass surgery are diabetic. We changed our techniques and we use skeletonized graft, means the artery is taken down and the veins along with the artery are kept on the chest wall. There was a study I will show you later on, where it preserves the blood supply to the sternum. And the most fear why most of the surgeons, they don't use this bilateral internal mammary artery is because of the fear of infection. But if you follow the protocols better, then the results are as good as you are using a single internal mammary artery. Glycemic control must be there, and this is how we do it. I will just show you in a next slide. So what the operation used to be seen on the left side is one internal mammary artery and two vein grafts on circumflex and RCA. All patients must get the bilateral internal mammary artery, because the results are shown that the survival after 15 years, we are not talking about less than 10 years now, 15 years, 20 years, the survival is much, much better with bilateral internal mammary artery. So why internal mammary artery? What is so special about this internal mammary artery? So it has a unique property that it dilates according to the demand of the blood, demand of the heart. If patient is doing some exercise, or if patient is running or walking, it dilates. And you see after 10 years, 15 years, if you do angiography, this has almost become as bigger as these coronary vessels. It secretes nitric oxide abundantly and continuously, as this is not seen with radial arteries, which has a muscle in its media. Internal mammary artery has very minimal muscle, so it is very less. I mean, I have not seen it goes into spasm so far, and the size is comparable to coronary arteries. So in diabetic patients, if you use a beating heart technique, the protection of end organs, we are talking about brain, kidneys, peripheral vessels. See, our body is actually provided with a pulsatile blood flow. And if we put the patient on cardiopulmonary bypass machine, it gives a continuous blood flow. So if you do the beating heart surgeries, the preservation of the end organs is better, and the recovery of these patients without complication is much better. And another morbidity what we see in this patient is because of the blood transfusions, multiple blood transfusion they get after surgery. So if we use a cell saver washed RBCs, I mean self auto transfusion for these patients, we have seen that the requirement of the blood product is very less. And if we use a myocardial preservation by intracoronary shunts, then the recovery of the patient is much faster. Another advantage of using bilateral internal mammary artery is we don't have to touch the aorta. Here you can see the right internal mammary artery is hooked on the left internal mammary artery, and the anastomosis is gone on the epicardial coronary blood vessels. So this no-touch aorta technique is very good for neurological events post-operatively. If we consider around about 1% to 1.5% of neurological events post-operatively, because we have to hook this proximal anastomosis on ascending aorta for the vein and the radial artery, this is completely unused, and the chances of getting a neurological event is 0.4% if you use bilateral internal mammary artery. And these are not because some calcium is going into the brain, but what we have observed, this complication when we use this bilateral internal mammary artery, because of hyperglycemia and because of atrial fibrillation that patient develops in the perioperative period. So we don't have any case in last 5-6 years which has developed this calcium dislodgement from the aorta or from the carotid circulation. So far in last 6 years, I have done more than 1,000 cases, and initial few cases we used the pump, but now 100%, almost 99.6% patients are done on pump, and almost all patients exclusively I use internal mammary artery. And as I told you, the diabetes patients will have multiple blocks, and we need to bypass all these vessels. And average graft per patient we do is around 4.5 with a success rate of 99.4%. So I will just want to share one of the diabetic patient here. This is the angiography, and you can see how diffuse disease is there. I'll just stop at one point here. Yeah. So this is the left main artery, and this is the LAD. If you see this up till this first septal, this is a first septal. This is a proximal LAD. There is a block here. Then again the mid LAD has a block here, and this is the distal most LAD. This portion. So this patient, what we do normally is we, in this patient I have done this diagonal artery which will cover the proximal LAD. Then I have done the mid LAD here, which cover this much portion, and again a jump graft on the distal LAD to cover this portion. So 3 grafts are done on the anterior wall so that this diffuse disease is taken care of. And this is the left dominant system. As we can see, PD is coming from there. So I'll just like to quickly show you this video. The standard median sternotomy incision we take, and this is the internal mammary artery which is been harvested. Skeletonized fashion means you don't see the veins which go along this artery. And this is the heart here. So similarly, the right internal mammary artery is also harvested. So this preserves the sternal blood supply almost 65%, which is radiologically confirmed by one study which was published in 2004. This is the right internal memory artery. Here you can see. After this, I check for all the vessels and we see whether it angiographically the site of confirm the sites for anastomosis and lateral wall, inferior wall of the heart are checked. And then you see here this left internal memory artery is kept on the heart in an easy way so that we know till how far it reaches. And this patient required a third graft in the distal LED, so we must know that this length is adequate for this patient. And then the Y is prepared after this as a free graft on the Lima. I'll just go quickly on this ahead. So this is being a Y anastomosis here, and this is the first graft going on. You see this diagonal artery which has a plaque which is a mixture of calcium and cholesterol, white and yellow thing, which is being done on a beating heart. And this is the octopus which fixes the heart, and that portion I do the endarterectomy. And all these patients, I do CT angiography after 1 year to see the patency of this grafting, what we are doing. And after each anastomosis, we check the blood flow through the internal memory arteries. Just run through ahead. And see if you can see the distal flow here. So all the time we keep on checking it, and we have one measurement tool. So now the second graft on the mid LED we'll do here somewhere. We palpate the artery, it should be calcium free there, and then there we open it. First we fix it with the octopus. And this is the last graft on this distalmost LED. See, you see the now appreciate the flow in the last for the last anastomosis. Sorry, it went out. Should be here somewhere. Yeah, so this is the last graft which was done, and then the lateral wall will be done. So I will not go in further details of this now. So in these patients, particularly with diabetic and smokers also sometimes, this LED may require big, long endarterectomies. And you can see this on this picture, the septal branches are also been endarterectomized, origins of them. So this gives a very good result. This patient particularly was a very young, 46 years man, and now 2 years this endarterectomy done, and his CT angio is patent. Another technique that we are using, as I told you, to single vessel proximal LED lesion is there, then we can do this Lima to LED advantage, because the stents, particularly in these patients, get early blockages. And in this patient, the angiography looks like this when the LED is blocked from the origin of the origin from the left main. And here there is no landing zone for the stent. Because if you put only LED stent, it will block this circumflex origin. So most of these patients, they put a stent from left main to the LED, and which is actually can be avoided by doing a mid-cap surgery from the fourth or fifth intercostal space, we enter and do this operation. So it's just a 2-3 minutes video. I will just share. See, the incision of normal sternotomy is here, and this is the incision for the mid-cap operation. The principle of the operation remains same. You have to harvest the skeletonized internal memory artery and then put it on the LAD. Only it is done through the left side. And in about 5-6 patients, I have used robot for this operation. Robot can give you, as Mangesh has told, that dexterity is very good and the harvest quality of the arteries are very nice. I don't recommend minimal invasive surgery when the patient's circumflex artery or posterior descending artery from the right coronary artery is involved, because the lot of evidence and papers have come out that it doesn't work. The quality of anastomosis gets affected if you are using more than 4 to 5 grafts through this minimal access surgery. The maximum results and the best results are only given when you put this internal memory artery to diagonal or LAD, two arteries. So this is the LAD, which is actually seen just in front when you open on the fourth intercostal space here, and it is fixed with the octopus, and this lima is being now anastomosed, and this is the after anastomosis how it looks. So the advantage is that lima to LAD, which has a patency of 88% after 20 years, with shorter recovery and minimal trauma to the patient, and the bleeding hardly is about 150 to 200 ml through this approach, because sternotomy bleeding is avoided. And how do we strategize to handle these diabetes patients? So all patients will need HbA1c, and if HbA1c is more than 10, we will admit these patients 2 days prior and we'll start insulin. If HbA1c is less than 10, then we simply admit patient 1 day prior, stop the OHA 12 hours prior. Some of the OHAs has also shown problems with the microcirculation. So those we need to stop quite early, at least 24 to 48 hours prior. All patients receive insulin infusion. Insulin, as we all know, that is an anabolic hormone in the body. So we start this insulin infusion at the start of anesthesia in the operation theater, and it is continued even after patient is extubated. We extubate patients after 7-8 hours of operation, but till next 24 hours it is on. And sugar checks are done in this first 24 hours, every 1 hour. And we keep the sugars below 180, our target is that. And after the discharge also at home, patient has to take insulin for 1 month. Normally the short acting HAI for 3 times in a day and long acting Lantus in the night. So till 1 month we need to support this sternal healing, and the insulin has shown better control of glucose than the OHs. So there are 2 schools of thought, that do we have to do too tight control of sugar or just a tight control of sugar. So there are a lot of studies have come. If we try to do the sugar control too tight, like between 100 and 150, then the chances of getting hypoglycemia and the scale management by the ICU people is very difficult. But at the same time, why we are doing it? To reduce the risk of infection. So even if you keep the sugar between 150 to 180, the risk of infection is same as if you want to keep it at 100 or 150. So there is no need, just keep it between 150 to 180. And most of the units, they now realize that even if you keep 150, 180, it is good. And bilateral, as I told you, that one paper was published in 2004 when post-harvest of bilateral internal memory artery, using two techniques. One is pedicle graft and one is skeletonized graft. If you do skeletonized, harvest 65% of the blood supply of the sternum is intact, as compared to 35% of skeletonized, non-skeletonized or pedicle graft, what we call. So these patients really definitely benefit by skeletonization of the graft. I thank everybody for listening on today on my topic, and if any questions are there, we can provide.
What is your opinion with exclusive Lima graft irrespective of age without radial and venous graft? In needed CABG, what is the advantage?
See, this is a very good question, because a lot of people, they speak that if the patient is more than 75 years, you should not use bilateral internal mammary artery. But I have done one operation on 83 years old just now, 15 days back, and all patients I use that, because even if you're 80 years and heart is the only thing that is holding you back, other systems are good, then why not to use this gold standard conduit for all patients? And there is no additional risk for this. There is no additional risk for using this. And if you use a skeletonized technique, the sternal infection rate is as same as single internal mammary artery use. Second question is, TAVI procedure can be done with the help of MICAS. What is the result and what is the cost? Yes, TAVI procedure is when you put a aortic wall from the femoral vessels or from the aorta. So this procedure was introduced in 2002 and it is now widely used across Europe. It was introduced in India and US at the same time of around 2012, 2013. And when I was in Texas Heart Institute, this was introduced in USA. So the cost of this procedure is about, if you use imported valves, it is around 22 to 25 lakhs. And if you use Indian made, our Merrill valve is there, about 12 to 15 lakhs. But TAVI is not for low risk patient or medium risk patient. The TAVI is for the patients who have quite other comorbidities, like the open surgical risk is very high in these patients. Earlier, it was done only in the patients above 80 years of age. And because probably as a physicians, we know that some patients only holding factor was severe aortic stenosis, but because of LV dysfunction and other comorbidities, we could not offer them open aortic wall replacement. That was the thinking process behind this. The longevity of these valves are porcine valves, and the longevity of the valves is yet not clear. So it is for the little bit higher age group, and that is how we use clinically.
Thank you, Dr. Bhamle, for giving such an excellent presentation and the problems diabetes patients have to face during bypass surgery. And the more difficult the surgery becomes because of diabetes, and how to manage them post-operatively. Thank you very much.
Thank you, sir. Thank you.
So our next speaker is Dr. Navrekar, Viraj Navrekar. He will be talking on the role of physicians in breast cancer, and Dr. Pragji will be introducing him. Dr. Pragji.
Good morning, everybody. Our next speaker is Dr. Viraj Navrekar. Hello.
Good morning, sir. Good afternoon, sir. Hello.
Dr. Viraj Navrekar is consultant at Department of Medical Oncology, HCG ICS Center, Cancer Center, Kolaba, Mumbai. He has completed his MD Medicine from the prestigious All India Institute of Medical Sciences, that is AIIMS, New Delhi, and DM Medical Oncology from AIIMS, Delhi. He has received his training at the Apex Institute of India. He has expertise in chemotherapy, targeted therapy, and immuno-oncology, and treats solid and hematological malignancies in children, adults, and all patients. He has a special interest in GI oncology, head and neck cancers, breast cancer, and immuno-oncology, as well as hematological cancers. He has keen interest in palliative care and preventive oncology. He is a member of European Society of Medical Oncology. Today, he will be speaking on role of physicians in breast cancer. So over to Sir, Dr. Viraj Navrekar.
Yeah. Thank you, sir. Good morning and wishing a very happy Diwali to everyone here. My topic is the role of physicians in breast cancer. So today the theme is diabetes. So when I was given this opportunity, I was thinking for a long time that how do I connect diabetes with cancer and present something novel. So it struck me that why not talk about the cancer, which is kind of diabetes. It's a diabetes of all cancers, that is breast cancer. Why you ask? It's because the general population, the general epidemiology that defines diabetes, the same epidemiology more or less defines breast cancer also. So you would have firstly, breast cancer is one of the commonest cancers. Breast cancer, the causative factors for breast cancers are the same that are there in diabetes. So you will find breast cancer in a highly affluent population, in those having sedentary lifestyle, and just like diabetes, it is now started affecting younger population also. So for all those instances, I reached the conclusion that why not start with breast cancer, which is somewhere close to diabetes. Another point is that why this topic, role of physicians. Breast cancer is such a huge field that if you go to the Western countries, then for each type of breast cancer, that is hormone positive or HER2 positive, they have their own departments for each subtype of breast cancers. So it's a huge topic, and covering everything in 30 minutes is a very difficult proposition. So what I thought was, and I have been a long proponent of this, that what can be role of physicians, the MD people, the general practitioners, who see a host, who do a community-based practice, what is their role in preventing, in treating, and in follow-up of our breast cancer patients. Can we go to the next slide, please? Yes. So with this in mind, I decided that let us do a bottom-up approach. A patient comes to you in your clinic, and then how do you contribute to the management of the patient? We can go on and on about hormonal therapy, about targeted therapy, about immunotherapy, but there is nothing as important as an early intervention by any medical profession. So my entire discussion would be framed as, first, why breast cancer, why physicians, what is their role in screening of the patient, what is your role in diagnosis of the patient, and ultimately what is your role in follow-up of the patient. Next slide, please. Yes. Now, while we talk about diabetes being one of the leading killers in the world, we can also understand that cancer too is the almost second leading cause of death globally. In India itself, in 1990s, we used to have around close to 6 lakh cases. Today, that cases has gone to 11 lakh cases. So it's almost doubled. Then we talk about breast cancers. Every year, close to 1.5 lakh breast cancer patients are being registered in India. These are the official figures. We don't know how many remain undetected. But that is the fact that almost 1.5 lakh breast cancers are detected in women in India today. The next comes cervical cancer, and other neoplasms constitutes only 55,000. So you can understand that breast cancer alone is 3 times as compared to other neoplasm, other cancers. Now, what is another interesting trend? I have shown one graph that just like diabetes, you can see that the blue, if you see the bar chart below, the blue denotes the incidence of, it is the age versus the percent of cases that were detected. So if you can see that 25 years back is the one in blue and the red is the present statistics. You can see that the incidence of breast cancer in young people is going on increasing. You look at the age group of 30 to 40, it's more than doubled. You look at age of 40 to 50, it has almost become 1.5 times. You look at 50 to 60, it is in fact coming down. So this pandemic of breast cancer is actually hitting earlier and hitting really hard. Next slide, please. Yeah, so I just explained that why we need breast cancer, why I have chosen breast cancer as a topic. Now let us understand that why physicians, what is the role of physician into all this? You see, now let us look at the percent of cases. Now the green statistics that I have just put, it's the Western statistics. Okay, so you can see that when we talk about a localized breast cancer, that is, it is just confined to the primary site. Almost 60% of cases detected are localized breast cancer. Regional, that means including of the regional lymph node, it is further 30%. Distance mets is only 6%, and unknown unstage is 2%. So concurrently, if you can see the graph next to it, then the localized breast cancer has survival of close to 99% at 5 years. So basically, if your cancer is detected at early stage, probably there is a complete cure. Nothing may happen to you. If we say at a regional, the survival of the regionally spread breast cancer, then it comes down to 85%. And the moment it becomes metastatic, it comes to 26%. So this tells us the importance of detecting breast cancer at an early stage. Extremely important. The second graph next to it is the incident per 1 lakh of population. And this is classified as stage 1, as per stage, detection of stage. You can see that from 1973 till 1998, you can see there is only one graph which is going above, and that is stage 1 graph. This means as the awareness is rising, the percent of people, breast cancer cases what being detected in stage 1 is increasing. And that is what it should be. The earlier we detect, the better it is, because we saw the survival. Next slide, please. Yeah. Now what I just showed you was the Western data. Now there was a study which classified on stage based on different cancer institute at different cities. Let us look what does that say in India. In India, if you see, look at the stage 1 part of it. Mumbai, Trivandrum, Chennai, Lucknow, all stage 1 detected cancers are within the range of 5 to 10%, less than 5 to 10% in fact. Look at stage 2, look at stage 3. So majority cancers are being detected in the loco-regionally advanced conditions. And stage 1 cancers, that is local cancers, are less than 10%. We just saw the Western data which was showing it almost around 60%. And here we have that we are not even reaching 10% of the cases in the primary stage. So that is really a worrying sign that early breast cancer is being missed. Either the patients are too ignorant about themselves, or it is not just coming to the notice. Now there was this article in Times of India which they had just got a cut sectional view. 80% Indians consult doctors when the recovery is difficult in cancer. You can understand 80% reach that point when the treatment is actually very difficult. Almost between the age group of 30 to 70, there is 70% of deaths in India. In US, more than half deaths are in those patients who are above 70 years of age. So in our country, the people are actually dying young. 70% patients die in the first year in India due to late detection. Now, this is the point to be noted, that almost we are losing more than 2/3 of our patients because they are being detected late. Now, again, we talk about lifestyle. It's a diabetes day, so nothing can go around without talking about lifestyle. 50% of cancers from lifestyle factors, obesity to tobacco use. almost 50%. Even in minors, the cancer rate is going to 15% as compared to global average of 0.5%. So that's what I'm telling, that this is where physicians play an important role. The point I want to again and again impress upon it, that that what we require is early detection of cancer. That is one place where physicians come into play, because because of the community practice, most of the patients who come to you are often asymptomatic. They come for some other reason, but might as well get cancer detected. So our physicians play a very important role. A robust awareness and robust detection system at that level will help us cut down this figure of 80%, will help us improve the figure to localize CA from less than 10% to possibly 60%, and that will lead to an improved survival, because around 80% of patients present to oncologist when it's already spread a lot. So there is very little that we can do at that stage. Next slide. So now I have chosen, because my presentation, my angle of presentation is more a practical day-to-day application of what to do when you are faced with a breast cancer situation at a physician level. So I have just made some case notes. Say a 55-year-old female comes to your clinic for routine evaluation. She has a primary complaint which you excellently address. And then she asks you, she is an educated lady, she has read about breast cancer, and she asks you about breast cancer and the required precautions. Now, what she must do now? Whether she must do a self-breast examination or breast examination by a physician regularly. Should she do mammography? Should she do both? Or since she has no symptoms, there is nothing that she must do. Next slide, please. So, let us talk here about breast cancer screening. Generally, what we do for screening, breast cancer screening, is an investigation called as mammography, which you all must be aware of. The salient points about this thing is that this is shown to have a mortality benefit. That is, a woman who undergoes regular mammography, she decreases the chances of dying due to breast cancer by 20%. Let me tell you that screening for cancers doesn't show to have a mortality benefit in all the cases. Breast cancer, luckily one of those cancers where screening has shown to have a mortality benefit. Why? Because these ladies come into are detected earlier and detected at an early stage, and because they are detected at early stage, we have seen the excellent results of breast cancer when the disease is just localized. So now traditionally the risk of breast cancer starts increasing from 40 years onward and increases further from 45 to 65 years. So this is the time that we must start targeting for screening. Now, if you look at sensitivity, then around it is 75% in breast cancer in women less than 40 years and 85% in women in 60 years. Now, why does the sensitivity differ age-wise? Because the more dense the breasts are, the lesser sensitive the mammography is to catch the disease. Okay. Second is that there is always a fear of radiation. It has very minimal radiation, and it has a somewhat chances of false positive. You are likely to get some lesion, detect some lesions which may not be breast cancer, but it is always better to err on the side of caution. Can we go to the next slide, please? So yeah, so this is what the mammography picture is. We generally have two views of mammography. One is a mediolateral oblique and one is a craniocaudal view. So this is how the breast is put between the two films and the film is taken. There are different types of mammography: film mammography, digital mammography, 3D mammography. 3D mammography is better, but for normal screening, film mammography or digital mammography should be more than enough. Can we go to the next slide, please? Yes, now let us have look at some of the guidelines, because the lady here is asking about what should be done for breast cancer screening. Let us look at what it says about mammographic screening. Different guidelines have different and different societies have different starting point of age for starting the mammography. but more or less everybody concurs that above age of 50, mammography has to be done. From age of 40 to 49, the guidelines differ, but it is always better to get it done because the American guideline, the NCCN, what we say, it generally says that from 40 years, the screening should start. It should be done every year. So every year, mammography screening is essential for any lady who is 40 years above. Can we go to the next slide, please? So that is what we talked about mammography. Another is the self-breast awareness or self-breast examination. Generally, it is recommended above age of 25 years. Unlike mammography, it has not shown to impact survival, but it definitely helps if there is an interval cancer between mammography. So self-breast awareness would be that that any lady who is reaches the age of 25, she must be made aware of a problem that she may face in future called as breast CA. She must regularly examine her own breast for feeling of any lump or feeling of any swelling. That is what she must do. So this is called as self-breast awareness. It is definitely wise to advise it, although data has not shown real breast awareness to impact survival. Can we go to the next slide, please? So in case 1, as we discussed till now, we would prefer her to do both annual mammography and breast examination. This is something that she must continue till the age. Actually, there is no upper limit for continuing it. But most people, if there are some comorbidities or if you are anticipating the survival to be less than 5-10 years, then you can, at the age of 70, you can consider stopping it also. But till then, definitely breast examination, mammography has to be done. Can we go to the next slide, please? Yes. Now we talk about the second case. Here we talk 60. Now this is so first case I talked about the role of physician in actually preventive or in early detection of breast cancer. Now let us talk about a second scenario that you may very easily face in your clinic. A 60-year-old female comes, visits your clinic. She notes a vague swelling in her right breast since last 3 months. It is increasing in size since last 1 month. It is painless and she has no other symptoms. Now, this is a common scenario that breast cancer patients actually present with. They have very minimal symptoms. They just notice a vague swelling and it is causing slight discomfort. It has been there since a long time. This is the common presentation that she has. Now, let's see what's ahead. Next slide, please. Yeah, so we go for examination. We see that there is a 6 centimeter by 3 centimeter swelling in the right breast. It is located in the upper and outer quadrant. It is hard, mobile, and painless. For every breast CA patient, we do check axilla also. So in right axilla, there is no lymphadenopathy. It is also must that we check opposite side breast also. So left breast, left axilla is normal. Rest of our systemic examination is also normal. Next slide, please. So what next? Now that it has come this way, see, I have been working for a long time in trying to allay the inhibitions that a physician develops the moment he realizes that a patient may have cancer. Because it is considered quite sinister, there is a taboo attached, and immediately the patient is referred to oncologist, which is fair enough, which should be done. But there is a lot of what I have realized over my practice at AIIMS Delhi and also in Mumbai is that there is a big lag time between a patient being referred to an oncologist and patient actually ending up being at an oncologist office. So that lag time can be reduced. And then the patient comes and then the oncologist reviews the patient and then he will order tests and then the patient will do the test and then he will come. So it takes a lot of, there is a lot of time wastage during that time. So I have been a proponent since long time that physicians must be, and they definitely should go for some baseline investigations that will help the oncosurgeon or the medical oncologist who is going to see next. So let us talk about what are the investigations that comes under purview of physicians, and it is absolutely okay if they, and it is actually preferable if they go for these investigations. First investigation in any suspicious lesion is bilateral mammography. Okay, so what does bilateral mammography help you to do? It helps to see if there is any other suspicious lesion, if there is a lesion in other breast, and the lesion that you are seeing, whether it is, what is the chance of it being cancerous. Mammography has BI-RADS scoring. I would have gone into detail, but that would have been unnecessarily prolong the entire presentation. But definitely it BI-RADS staging is basically it classifies into the risk of the lesion being cancerous. So higher the BI-RADS, the more severe, more dangerous it is likely to be. Next is, if the mammography suggests BI-RADS of around 4 or more than 4, then we have to consider core biopsy of the breast mass. Often what we do is that FNAC is done, but let me be clear that FNAC is of minimal significance, and even if FNAC is positive, we will ultimately have to do biopsy. So definitely core biopsy of breast mass is highly advisable. If it is better if you can get it done from your end itself. So it is can be done by a radiologist as well as a surgeon. Before doing a breast biopsy, my mammography would be required to pinpoint the exact location, and most of the time if the lesion is advanced, we get it done from radiologist itself. As I said, FNAC is of minimal significance and biopsy is mandatory. Third is that when you order biopsy, the breast, you have to order for 3 more things. Actually, breast, these things depend on the pathway by which the malignant cells in breast C are activated. Either they're activated by estrogen receptor and or progesterone receptor and or HER2 receptor. Sometimes all 3 can be negative also, but this is another mandatory thing that needs to be done when a biopsy is ordered. Because if these things are not ordered, then again the patient has to review his biopsy, and again that takes up a lot of time when the patient goes to oncologist. So we would really love if all these investigations are done before the patient is sent to us. Can we go to the next slide, please? Now, imaging of the body. What we talked about is basically evaluation for mammography to see the breast and to confirm it with biopsy. Now that there are different guidelines for imaging on this extent. It is largely believed that if the tumor is small in size and if there are no axillary lymph node involved, then the chances of there being metastasis is very less. So the guidelines say that if the tumor size is less than 5 centimeter and if there are no axillary lymph node involved, then there is no need for intensive workup. Patient can in fact directly be sent to surgeon. But if either the tumor is more than 5 centimeter or if there is an axillary lymph node present, then a whole body PET scan is preferred. Because if you don't do PET scan, then you might have to do CECT, chest, abdomen, pelvis, and a bone scan. So sometimes a PET scan is actually better than ordering 2 investigation. But it is done if the tumor is more than 5 centimeter and if axillary lymph nodes are involved. Lastly, appropriate referral. After doing all this investigation, it is preferred if you send it to an oncologist or an oncosurgeon for further management. Can we go to the next, please? To summarize what we do in case 2 is, we would go for bilateral mammogram, we will go for biopsy of the mass, histopathology with receptor testing, and we would give PET-CT scan because the patient's lesion is more than 5 centimeter. Finally, we would refer it to oncologist. So simple 3 investigations can help patient a long way and also help surgeon, oncosurgeon to immediately take up the patient for surgery. If the PET scan shows any kind of metastasis, then the person would be straightaway referred to medical oncologist for targeted therapy or for chemotherapy. Next slide. Just a peep in NCC guidelines. What does it tell for baseline investigations? Obviously, history and physical examination, bilateral mammogram, pathology review, determination of receptor status. Then there are CBC, LFT, KFT, PET-CT scan. You can either do a PET-CT scan or a CECT with bone scan. So this is what NCCN guidelines tell. And this investigation, if you don't do, then in the end, oncologist will anyway have to do. But if the investigations are ordered earlier, the time would be saved. Next slide. Now we come to the last part, is that we talked about detection and prevention. We talked about treatment part when patient is diagnosed. Now let us tell, because see, a patient has a lot of faith on the physicians. So once the cancer treatment is over, then many of them like to follow up for their routine thing with their own family physicians. And this is where it can you can play a very important role. So here we have a 65-year-old lady. She's a survivor of breast cancer. She has undergone surgery, chemotherapy, radiation, and is now on hormone therapy. She receives 2.5 milligram of letrozole once a day since past 2 years. She is asymptomatic and wishes to follow up with you, as I said. Next slide, please. So what next? What do you have to do in a patient who's following up on breast cancer treatment? Now, for first 5 years, generally we prefer, if the patient is a localized CC, let me say, if it's a metastatic case, if it's a stage 4 case, then the patient would anyway be in follow-up with an oncologist. But in a patient whose treatment is over, I'm talking of those patients. Every 3 monthly history and physical examination should go on at least for 5 years. And after that, you can do a yearly examination. Then yearly bilateral mammogram. This should continue to be done. So every 3 months, you will examine the patient, ask him for symptoms, check the breast, and every year you will go for bilateral mammogram. If there are no symptoms or clinical findings, routine testing for metastasis is not indicated. I have often seen patients being ordered CT scan, PET scan on follow-up. It is not really necessary. If the patient doesn't have any symptoms, then simple history and physical examination is more than enough. Third is that promotion and encouragement of healthy lifestyle, ensuring patient maintains BMI between 20 to 25. Now, some patients are on hormonal therapy. Now, what these first 4 points I have told, it is irrespective of which type of cancer patient is. Now, there are some patients who are on hormonal therapy. If the patient is on tamoxifen, then an annual gynecological evaluation is necessary, because there is an increased risk of uterine CA. Next slide, please. If a postmenopausal woman is on aromatase inhibitor like letrozole, as in this case, then what are the things that we do? Here we do a DEXA scan at least yearly, because when you give letrozole, you do estrogen suppression, there is an increased chance of osteoporosis and fracture. So in order to prevent that eventuality, we have to do a DEXA scan at least at the baseline, and then it is to be done as required, but normally I prefer doing it once in a year for a patient who is on letrozole. These patients are also likely to develop many bone related issues. They may have bone pains, they may have some kind of, I have even seen patients developing carpal tunnel syndrome because of letrozole. So in that case, we have to stop letrozole, but that would require a follow-up with an oncologist. But this is what you have to understand. Second is injection zoledronic acid has to be given 3 monthly for at least 3 years. It would be in most cases be prescribed by the oncologist itself, but patient prefers to take this medication with his physician often. Third and last is calcium and vitamin D supplementation. So any patient on letrozole or on hormone therapy needs a special care to his bone situation. Next slide, please. Yeah, so what would we do in this case? We would go for an annual mammogram. We would go for a DEXA scan annually. We will ask the patient for weight control. We will give zoledronic acid and calcium and vitamin D supplements. This is all that would be, and of course, 3 monthly follow-up with breast and systemic examination. This is all that we would be requiring in this patient. Next slide, please. So I have tried to cover what an important role that physician plays in this early diagnosis, and because this topic is very close to my heart, about patients being missing out, patients being delayed because of lack of diagnosis, lack of early diagnosis. Hence I chose this topic on today's day. Now my points are that physicians, that you are first point of contact for the patient. There is an immense trust factor of patients with physicians, and the compliance is also very high. I have seen patients believe their physicians more than the oncologist, and hence it is very important to keep physicians in the loop regards treatment. They are more likely to detect cancer in early stage. They are more likely to play a role in screening exercise. By involving themselves in baseline investigation can significantly reduce time to treatment, and obviously can help in addressing long-term follow-ups and quality of life parameters. This is extremely important because breast cancer, more earlier they are detected, the patients are having long and healthy life, and they would love to follow up with you people, and then they have small issues which you will have to deal with. So with this, next slide please. With this, I would like to thank you all, thank IMA for providing me this opportunity, and also thanks all the physicians for their immense contribution in management of cancers. Thank you.
If there are any questions?
Yeah, I have a couple of questions here. One is Dr. Rajan Patel has asked about how to detect carcinoma in situ. Now, ductal carcinoma in situ can also present as a lump, and if you are engaging the patient in an annual mammogram, it can also be detected in mammogram. So that is one thing. So if it presents as a lump, then definitely you would be evaluating it in the routine way. In almost all cases, mammogram is enough to tell if there is something abnormality, and when you biopsy it, you would realize it is ductal, if it is carcinoma in situ. So yes, the patient can prevent with the lump. You would need to do mammography, and then it would also require a biopsy for diagnosis. My next question is, can a plain CT chest detect breast cancer? You see, if there is a malignant mass, then yes, CT scan chest, if it includes the breast, so yes, it is likely to be detected. But the problem there is twofold. One problem is that is the radiation exposure. The kind of, if we decide to see if it is incidentally detected, then that is all right. But if you are using CT scan chest for routine screening, then it exposes the patient to a lot of radiation. Mammography is just like an X-ray. It's another version of X-ray. So its radiation exposure is very less. So that's what I would prefer, that if the patient has breast, and mammography gives a better resolution also. So yes, sometimes it happens that you are doing CT for some other reason and you end up finding breast cancer. That's a different story. But if you are suspecting breast cancer, it is better you go for mammography in the first place. I have yeah.
Any other question?
There is another question, which is the best hospital to rule out CA breast in Mumbai. See, if this is a very open-ended question, actually, I feel that any physician is good enough to rule out. If you have a confirmed breast cancer, then it's a different story. But if you simply have a doubt and want to rule out, you can go to any physician, get a mammography done, and then based on that report, we can see how to progress further.
Anyway, thank you, Dr. Navrekar.
Yes.
For
thanks a lot.
Involving the physicians today in a holistic approach to breast cancer, right from screening to the follow-up, and also a practical method of presentation of your cases. Thank you very much, sir.
Thank you.
So we have a next speaker, Dr. Saurav Beswal, who will be talking on the practical approach to insulin initiation. And I request Dr. Jitesh Mehta to introduce him. Dr. Jitesh Mehta.
Yeah. Friends, Dr. Gaurav Beswal is a consultant in diabetes and metabolic diseases at the Sir H.N. Reliance Hospital, H.N. Reliance Foundation Hospital and Research Center. He is the founder of Good Hope Diabetes Clinics, located at Opera House and Matunga, Mumbai. Dr. Gaurav Beswal graduated from the GS Medical College and KM Hospital, Mumbai. He then moved to the UK for specialist training, where he was awarded the MECGP. He then received certificate in gestational diabetes mellitus and certificate in diabetes care from University of Warwick, UK. He also did a postdoctoral fellowship in diabetology. He is an expert in advanced diabetic technologies like insulin pump therapy, ambulatory glucose monitoring, diabetes in pregnancy and children. He has authored book chapters on DPP-4 inhibitors in World Clinics of Diabetology. He has done research and written theses on frequently sampled intravenous glucose tolerance tests. He has been a speaker on diabetes in national and international conferences. Today, Dr. Beswal will speak on practical approach to insulin initiation. A warm welcome to Dr. Gaurav Beswal.
Thank you very much, sir. and wishing you all a very happy Diwali and also very happy World Diabetes Day. So good morning to one and all, and thank you for IMA for organizing this event. I'm Dr. Gaurav Beswal, and let's move swiftly to the topic of insulin therapy, a practical approach. The structure of my today's talk is what is the history and background of insulin therapy, types of insulin, when to start insulin, how to start and titrate the dose, what are the devices and injections available, techniques available. So today is yesterday was the World Diabetes Day, and let's remember Sir Frederick Banting, and along with him his colleagues Charles Best, John McLeod, and James Collip, who are the people instrumental in discovering the insulin therapy. World Diabetes Day is celebrated on the birthday of Sir Frederick Banting. Just a quick background so that, see, we all treat people with insulin. It's good to know a little bit of history in our profession. So Frederick Banting was a Canadian doctor who first discovered the idea of insulin when he was delivering a lecture to his medical students. And he approached his mentor, Dr. McLeod, and along with his assistant, Charles Best, they isolated insulin. This was Banting and Best. And this dog that you see is called Marjorie. They first tied the pancreatic duct in this dog, and they isolated insulin and they re-administered the insulin to this dog. And they found that she recovered. The first human patient to receive insulin was a 14-year-old boy with type 1 diabetes called Leonard Thompson. And this was in 1922. And we are fast approaching 100 years of diabetes, which is a milestone. The initial few, and this was him before and after. Now, just a quick trivia. What happened before 1922? There were no oral medication. Even metformin came up in the 1950s and 60s. And it was not popular in the US till the 1990s. They didn't believe in metformin. So the only therapy before that was severe calorie and carbohydrate restriction. People were allowed only 500 calories a day. They were allowed very little carbohydrate. And it was very, very difficult for patients to sustain their life. And due to severe calorie restriction, they slowly wasted away and died. And then came insulin, which was a wonder therapy. And initially, insulin therapy was also riddled with problems because the insulin at that time in the 1920s was isolated from the pigs and the cattle, the cows. And they had a lot of impurities. And a lot of times when they gave these insulins to patients, they had a lot of reactions because of the extra proteins that these insulins have. And then we had the insulin processing. Gradually, we understood what is insulin. This is the proinsulin, which is an alpha chain, beta chain, and connected by a C-peptide. What is the practical utility of C-peptide, which I'll talk about? In the body, when proinsulin is made, it is made like this as an alpha chain, beta chain, and C-peptide, and then it is cleaved with the endopeptidase into a mature insulin, which is a alpha chain, beta chain connected by a lot of sulfide bonds, plus another sister molecule called the C-peptide. Now, we frequently do the C-peptide test in type 1 patients. Whenever we want to check whether a patient's pancreas are making insulin or not, we check the C-peptide, not the insulin, because C-peptide is a much better marker. Because even if you're giving insulin from outside, the serum insulin may change, but the C-peptide does not change because that measures the endogenous insulin production. So it has a very important practical utility. This is an insulin hexamer. And this is what the human insulin molecule looks like. It has a lot of amino acids and it has a lot of linkages. And I'll tell you why this is also important, because later on, we did genetic engineering on these amino acid sequence, and we have our modern.
Can you increase the volume of your talk?
Okay, is it better now? Hello? So the amino acid sequence of, these are the various species, the human, porcine, and bovine. And what is the difference between these insulins are basically the amino acid sequences. So you have, I'll not go into much detail because I want to go to the practical part. You have the human, you have the porcine and bovine. And then you have the analogs. So initially, insulin was isolated from porcine, which is the pigs, and the bovine, which is the cows. And they purified it and they gave it to the humans. And I'm sure a lot of you will remember in the 1980s, this was very popular. And then came the human insulin. Human insulin came after we were able to identify this genetic sequence, this amino acid sequence in the 1970s. As soon as we identified that, we could reverse engineer the human insulin in a lab. Of course, human insulin is not isolated from humans. It's basically genetically engineered on the back of E. coli or certain fungus in a genetic engineering lab. And we get the exact human insulin, what we call the normal human insulin. A popular brand name is Actrapid. Actrapid is basically a pure human insulin. Later on, to change the release profiles of insulin, we made some changes to the amino acid sequence to make it fast acting or slow acting. And we also added certain protein molecules so that they could last longer. And this is what we'll discuss later in this slide. So why did we need human insulin? Because the animal insulins had a lot of impurities. When you gave them, there was a lot of antigenicity and allergic reactions to that. And it was not because of the amino acid sequence. It was mainly because of the impurities that were there. Then, of course, you have the human sequence. And it was basically a difference of 1 or 2 amino acids. It was not a huge difference. So with the DNA sequence, we could use E. coli and make the human insulin. Insulin therapy. So prior to the 1970s, they had a lot of impurities, like I mentioned, and that caused lipodystrophy, which is still there in our textbooks, which doesn't happen very often now. Insulin allergy, we developed antibodies to insulin, and there was a lot of immune response. I'll skip through these ones because we'll focus more on the practical aspects. Now, you have something called a basal and bolus concept. Now, when the human body, now giving the exact pure human insulin from outside is very different from the way our body generates insulin. Now, our body generates insulin from the beta cells of the pancreas. It secretes it directly into the bloodstream. When we give insulin from outside, it is given in the subcutaneous tissue. And the release profile is very different. Okay, so the end result is very different. Now, when we secrete when the body secretes insulin, there's a basal insulin that every few minutes the pancreas is releasing insulin. And why has nature designed that? Because there's a homeostasis of glucose. Our liver has a storage form of glucose, and overnight when we are sleeping or when we are fasting, the liver is still supplying glucose, and the body is secreting the insulin mainly to take care of that glucose. Basically, the job of insulin is to detect the glucose and to drive it either to the muscles, if the muscles are active, or to the various tissues of the body. So the brain, the heart muscles, and all the body organs, they run on glucose. We are basically an organism which is dependent on glucose for our functioning. And the key to this glucose utilization is insulin. And this insulin drives the glucose. It's a vehicle for the glucose to drive it to the cells and the heart muscles and all the muscles. And even when we are sleeping, to keep us alive, we need glucose and insulin. So that's the function of basal insulin. Next, you have the prandial insulin, the bolus insulin. Now, as soon as we eat food, the glucose release from the liver stops. It's like a traffic signal. And there's a red light shown to the liver glucose. We don't need that anymore for some time. And the insulin, the glucose from the food comes. As soon as we eat food, the carbohydrates are broken down, it releases glucose. And suddenly, there's a huge amount of glucose in our bloodstream, which is detected by the pancreas. And it secretes a huge amount of insulin to take care of that glucose. So these are the two ways that our body switches from basal insulin to a bolus, which is a sudden amount of large insulin. After we eat food, the sugar peaks at 1 hour. and gradually it starts falling. And in a healthy individual, by 2 to 3 hours, the glucose is back to its original state. And after 4 hours, we are no longer in the prandial state. We are back to almost the fasting. Now, the job of the insulin, again, once we get the glucose from the food, is either to drive it to the skeletal muscle. So if we are exercising, running, all the glucose would go to the skeletal muscle, or it would go to the basic physiological functions. Any amount of extra glucose is stored as fat. So insulin is a metabolic hormone. It utilizes glucose for energy. It also stores glucose for energy for later use. So glucose should not be present in our bloodstream. It has to be either burned or stored. And that is what the insulin does. And if there's too much of glucose in the blood vessels, it basically is corrosive. It damages the endothelium, and that is the trigger point of all the complications of diabetes. So I hope this was an important, good background to what diabetes and insulin is. And this is how our body makes insulin. This is the meal glucose. Also, insulin is released once we eat food in 2 phases. One is first phase and second phase. As soon as we eat food, our body has certain amount of insulin already stored. They are like the rapid acting, they are, because to generate insulin and to secrete takes time. So our body makes insulin pre-prepared, pre-packaged. Think of it like a restaurant. If you go, if it's a very fast-moving idli restaurant, they will not make idlis after you order. They will keep some idlis prepared, and as soon as the customer comes, they would deliver the idli, and they would keep making it in the kitchen. That is how our body is. So they would, as soon as the food enters our mouth and the stomach, the insulin is released, and then the rest of the insulin is made depending upon the glucose rise. This is the first phase and second phase. And this first phase is lost quite early in diabetes. And to match this, we need the basal bolus. So this was a background. And of course, insulin release is triggered by GLUT2 in the beta cells and GLUT4 in the peripheral cells. Okay, so coming next to the types of insulin. What are the different types of insulin? So mimic the body's response. Firstly, we have, like I mentioned, porcine, bovine, and now the human. Now, porcine, bovine is obsolete. It's no longer manufactured. There's no use of it. Now we are left with either human insulin or the analogs, which is a genetically modified form of our own insulin. This is regular human insulin. Once we add NPH is also something that we have heard of. Now, NPH insulin is basically called neutral protamine hagedron or isophane insulin. And the popular brand name is Insulatard. What happens once you add a protein to it and some zinc to it, our same human insulin, the Actrapid, it becomes long acting. It starts working for 14 to 16 hours. And when you use a popular mixture of insulin, we all know of 30-70 insulin, especially like Mixtard. This is basically a combination of regular human insulin, which is a short-acting insulin, and this NPH, which is a mixture on a 30-70 format. This was also discovered quite early on. And this works in 1 to 2 hours. It peaks in 6 to 12 hours. And the duration of action is quite variable. Sometimes it's 16 hours to 24 hours. So it's not a very, very great basal insulin, although this was the first basal insulin to be discovered. You also had Lente, which is no longer used. I'm sure this is something which we all read in our textbooks, which had Lente and Ultra Lente, which was mainly made long-acting by use of zinc suspension. But this is obsolete, no longer available. Lente is not to be confused with a popular brand called Lantus, which is a completely different thing. Lente is different, no longer in use. Lantus is different. So this is what I've talked about, a popular brand called Mixtard, which is a mixture of human insulin and NPH. Next came the analogs. So now the scientists had become smarter. They started changing. They realized, the basal insulin, the NPH is good, but it's not good enough. We need something which can last longer, for 24 hours or longer. And once we give it, it should be released very, very slowly into our bloodstream. So then they deleted certain amino acids, added some proteins, deleted some proteins, and then came the better basal insulins, which could last very, very long, better than NPH. And they also could make the human regular insulin. So think of the regular human insulin, which is Actrapid, as a basic template. And they started tweaking around with that. When they also tweaked around and made the regular human insulin, which was a short acting, into a rapid acting insulin, which we know as popular brands are NovoRapid or Humalog. So then you had the Lispro insulin, which is the Humalog, which is a fast, rapid acting insulin. Aspart, NovoRapid, which is a rapid acting. Yeah, and this is the difference between a regular and a Aspart. Now, Aspart works very, very fast, and it also comes down fast. So it is closer, but not perfect to our own endogenous mealtime insulin secretion. If you compare that with the regular human, it has a slow rise and a slow fall. You also had the Epidra, which is another rapid acting. Inhaled insulin was there, but we'll not delve on it today because it was not a great success. Now it is coming back. Glargine is one of the most popular and the most widely used slow release insulin. Again, it is made by substitution of certain amino acids. And that brand name is called Lantus. And this was Glargine. When you compare it with the NPH, NPH has a peak and a trough, but Glargine is a very slow release and 24-hour acting insulin. You also have Detamir, which is the long acting, again, not very popular now. So this is an important slide for those, very, very relevant. Now, I've compiled two slides. One is the human insulins available in India, and the other one is the analogs available in India. And a lot of times there's a lot of confusion as to what is Actrapid, what is Lantus, what is this, what is that. So if you have a look at this slide, look at the columns. One is regular human insulin. Then you add certain protein and make it longer acting called the NPH. So this is the basic template. When you mix these two in a pre-mixed format, in a 30-70 format, so you put 30% of this regular human insulin and 70% of NPH, it becomes a 30-70 premix. And when you mix these two in a 50-50 format, it becomes a premix 50-50. So the difference between 30 and 50 is basically of a larger portion of the regular insulin or a short-acting insulin in 30-70. I've also written the brand names, and these are the main companies. It is certainly not a complete list, but a list just to give you a basic idea and the more popular brands. So you have companies like Novo, Lilly, Lupin, Biocon, Wockhardt, which make this. And these are their brand names. If you just look at the first one, you'll get a better idea. So Actrapid is a regular human insulin, Insulatard is NPH, and Mixtard 30 is 30-70, and Mixtard 50. And if you look at any one, let's take Insugen. So R means a regular human insulin. So this will really help you in your practice. So if you look at R insulin, it will be the regular insulin. N will be NPH, 30-70 and 50-50. So let's move on to the next slide. Now this is the basic guide of the analogs. So in analogs, we don't call, the nomenclature is slightly different. When we talk about regular insulins, we talk regular or short acting. But when we use analogs, we say they are either rapid acting or ultra rapid acting. So these are the brands of rapid acting insulin: Epidra, NovoRapid. Now we have Fiasp, we have Humalog, Eglucin. So these are all the rapid acting insulins. What about the basal insulins? So Lantus is a very popular basal insulin. Levemir no longer much in use, it is there, and Basalog. So these are all good basal insulin. Then most of the analogs, when we talk about basal bolus, we use, let's say, either a Lantus or a NovoRapid. So that is what the idea is. You also have certain better and newer generation basals available, which is 2GU, which is Lantus in a more concentrated form, which not just works for 24 hours, but it works for 48, sometimes 72 hours. You also have Tresiba, which is ultra long acting. Then you also have a premix. Premix is not a mixture of Novorapid and Lantus. Premix is basically a mixture of Novorapid and protaminated Novorapid. So if you have a Novorapid and NPH form of the Novorapid, it becomes Novomix. Lantus you cannot mix in the same syringe as the Novorapid because this is more acidic. However, Novorapid and Tresiba can be mixed, and that mixture is called Rhizotec. So this is the only true sort of co-formulation there. All the others like Novomix 3050, Humalog, Eglucin, these are all mixtures of rapid acting and protaminated. Now, having known about what are the types of insulin, when do we start insulin? That's the most practical approach. Now, to give you in a nutshell, the beta cell declines whenever a patient is diagnosed with diabetes. At the time of diagnosis, 50 to 80% of the beta cells are still already inactive. We start with drugs, the oral medication, and within 5 years, the beta cells have declined a significant number. As soon as you reach metformin plus 2 other agents, let's say you are on a combination of 3 different agents, and if the patient is still not in control, which means that A1C is not in target, you need to set the target, and the target usually is 6.5 or 7%. And if they're not in target, it's time for insulin. Nowadays in practice, although the guidelines say 3 OHAs, in practice we give 4, sometimes 5 as well, but that's not very ideal. My personal cutoff is usually if you're on 4 OHAs and you're not in control, it's time for an insulin. 5 years onwards is an average time, and by the 15th year of having diabetes, most people will require insulin. Like I said, 50% of beta losses already happens at diagnosis, and yearly another roughly say 5% loss also happens. So if you do a rough calculation, if you do 5 into 50, 50% extra loss happens in 10 years, and 50 is already lost. So by the 10th year, the beta cell is at its trough, very little beta cell downstairs. And 3 OADs maximum dose, A1C still over 7, and duration of diabetes more than 5 years. This should give you a rough indication that the patient needs insulin. But by no means this is a protocol. It's not a protocol, it's a guideline. Each patient is very, very different. There are some patients who have taken good care of their lifestyle. They've probably maintained their insulin production, either genetically or through lifestyle. They will probably never require insulin in their whole lives. I have 80, 90-year-old patients who don't require insulin, and they've had diabetes for 30 years. My average patient requires insulin by 10th or 15th year. And there will be some outliers who will require insulin within their first 5 years of diabetes. Probably because they've had an undetected diabetes for more than 5 years before that. Because you may diagnose their diabetes today, but you don't know how long they've had it before if they've never checked it. Now, so the basic idea is we must counsel our patients that they should always be under target. The end result when we are doing the therapy is that A1C should be within 6.5 for most, and some people 7. That is the end goal. It doesn't matter how, what combination of tablets they take, what insulin, whether they are maintained by lifestyle. So this is something that we should really counsel our patients, to not lose sight of the goal. And to move swiftly, we should not have that delay. Now, this is a good AACE guideline summary. AACE is American College of Clinical Endocrinology. And it also says when to use insulin either sequentially. So there are 3 approaches. One is if the patient, when you first detect their diabetes at entry level, if they only have mild early diabetes where entry A1C is less than 7.5, you can start them with metformin only. If their entry A1C is 7.5 to 9, only metformin will not be enough. So it's better to have a predictive approach to diabetes rather than reactive approach. Now, predictive approach will be, yes, I know metformin will not be enough, so let me start them with a dual therapy, usually a metformin with a gliptin or a SGLT2. Sometimes you also need to give them triple therapy right in the beginning. If their A1C is more than 9, And if they have severe symptoms like polyuria, polydipsia, weight loss, then it suggests that they are insulinopenic, and you may need to give them a short course of insulin right in the beginning. So a lot of my patients, you may see that for 1 month, I'll give them insulin in the beginning if they have severe symptoms and if their A1C is high right in the beginning. So this is when we give insulin right in the beginning of the therapy, and often this is short term. It's not a permanent insulin. The second approach is once they're filled on OAD, maximum doses of 3 to 4 OADs, and we give them insulin. And now we want to start them insulin. And this is the main core of my talk today. So if you've been wondering in your thoughts, now is the time to listen with all ears. The best insulin to start off in, as per all guidelines, is basal insulin. Indian guidelines may differ slightly for the sake of convenience, but in my experience, I agree with the international guidelines that basal insulin is the best drug of choice when we are starting insulin. How to start insulin should depend upon what is their sugar currently and what is their weight. Few years ago, we gave a very, very simplistic approach that you just start out with 10 units and you titrate it up. But that leads to a very, very long time lag. A better approach is based on the weight and the sugar. Let me give you 2 examples. So if you have a 60 kilo lady whose A1C is 7.5 and she's on 3 drugs already, maximum dose. Let's say she's on a glimepiride 4 mg, metformin 1000 mg, and you're also giving them a DPP4. A1C is 7.5. You would need to start her on insulin. You will not tell her that your sugar is only slightly above target, doesn't matter. You would want to give her insulin. So you would choose this approach. So A1C is less than 8, and you would choose either 0.1 to 0.2. So if she's 60, 16 to 0.2 is 12 units total daily dose. So you can start her with 12 units. Let me give you another example. Let's say you have a 80 kilo man whose A1C is 12% and he's already on a lot of OHAs. So you would give him 8 3s are 24 units of insulin. So that is how your starting dose of insulin differs. You can't both give them 10 units and up titrate. It will take a very, very long time. So if you use this approach, you will have a much better individualization for the patient. So that lady has needed 12 units and this man has needed 24 units starting. Now, every 3 days, you should up titrate the dose based on the fasting glucose. So let's say you started that man on 24 units of insulin. Here you can have a better simplistic approach. You can ignore what is written here. If you're in a specialist setting, let's say I would do this because I can directly approach it. If their fasting sugar after a week is still more than 180, I will directly jump them off by 4 units. But if you're giving instructions to the patient, you can give them simple instructions that I want you to increase the dose by 2 units of basal insulin every 3 days till you achieve a fasting sugar of below 120. So this is something which you can follow in primary care, or you can give simple instructions to the patient. The next question is, when do we consider prandial insulin? Do we consider it now? And what is the role of premix? Now, this is, I'll skip this one. I'll go back to this. Now, patients and physicians alike would ask, what is the maximum dose of basal insulin we can use? So firstly, there is no maximum dose. Whatever dose brings the patient into a normal fasting glucose is the right dose for them. So I have some patients who require 60 to 80 units, and some patients are well controlled on 20 units. But to give you a rough rule of thumb, roughly half the body weight should be a maximum dose before you start thinking out of the box, thinking of prandial insulin. So for that 80 kilo man, if he's titrated up and come up to 40 units, and if he's still not at target, then you should think, does he require prandial insulin? Second scenario is, if his difference between the fasting and the postprandial is quite high. Let's say you've given basal insulin 24 units, and his fasting comes to about 150. But when you check his prandial insulin, it is 300 or 350. There's a huge difference. roughly if there's a more than 100 milligrams of deciliter units of difference between the fasting and postprandial, 100 to 120, that should prompt you to think that he will probably require prandial insulin along with the basal insulin, and you may start them off very early. Third scenario is right in the beginning. If you study their fasting and post meal, if the fasting is generally, let's say 200, and if the post meal is vastly different, let's say 400-ish, more than double, then also it should give you a trigger, an idea that only basal insulin will not be enough, and you can start them on prandial right in the beginning, right? But to keep a simple approach, I think you should start off with basal insulin and sequentially think of prandial insulin. What will guide you is a very, very basic but important tool, which we should never forget, is self-monitoring of blood glucose, SMBG. We should counsel our patients, encourage them to do a 6-point testing, which is immediately before meals and about 1.5 hours, 90 minutes after meals. 2 hours is not that accurate because by the second hour, you don't get an idea of the peak. So 90-minute post meal is one of the best times to do it, and compare that. You do get that profile for breakfast, lunch, and dinner, and you'll be able to titrate the insulin therapy much better. This I've already discussed, that you start off with 0.2 to 0.3, and you keep on titrating up the basal up to half their body weight, and then you can add the bolus insulin. Bolus insulin, you can start with a low dose of 4 units to 6 units. Roughly, if you're looking at any patient, if they're on basal bolus therapy, this should roughly be in a 50-50 proportion, roughly. So if you see a patient who's just getting 10 units of basal insulin, let's say 10 units of Lantus and 12 units of Novorapid, some bells should ring in your mind. If they're on 24 units of basal and 888 of Novorapid, that should make sense to you, that yes, it makes sense. However, the basal and bolus requirements will differ depending upon the insulin resistance. So if the patient is very old, very frail, very thin, then their basal requirements will be very, very less. So in that case, if you see a patient and say, okay, this is very old, very thin patient, then their basal requirements will be very less, maybe 10-12 units, and their prandial will be. In summary, the basal insulin, more obese the patient is, the more basal insulin they'll require. That is the function of basal insulin, to stop the sugar release from the liver, the hepatic glucose. Prandial insulin is more to do with the beta cell dysfunction. So in type 1 patients or patients who have had diabetes for very, very long time, who've had very little beta cell mass, they will require more of prandial insulin. And of course, you have the premix concept. Premix concept is basically a mixture between the two. It is not very much encouraged nowadays, especially in specialist care, because you cannot do justice to the fine tuning. It's okay to reduce the number of pricks. It has its utility. I'm not saying it doesn't, but the utility is very, very less. And when I would use it is basically if the patient is hell-bent not to take number of injections. If there are caregivers who cannot get to the patient on every 3 times a day, then you may give premix, but it is nowhere as superior to a basal bolus. So yes, definitely to get a better control, basal bolus is favored. And nowadays we don't use sliding scale, we use a concept of correction scale. Sliding scale is you check the sugar and you give the insulin. Basal bolus correction is before the meal you predict that there will be some rise in the sugar and you give it accordingly. Are we okay with time, sir? Or shall I move on to the insulin techniques quickly?
I think the techniques are important. We should continue.
Sure.
Yeah.
Okay. Thank you very much, sir. Now, you can give insulin in 2 ways. One is IV and subcutaneous. IV is usually used in the hospital setting. If a patient comes with DKA or any diabetic emergencies like HHS or DKA, then we want to get insulin into their bloodstream very rapidly, and we would give them IV insulin through a syringe pump. But in the home setting, of course, we do not give it. Most common use is subcutaneous. Now, when we give insulin, the needle is very, very fine. It is 4 mm, 5 mm, 6 mm at the max. And this insulin is given in the subcutaneous tissue. And from there, the capillaries will absorb the insulin. A rapid-acting insulin will be absorbed immediately. And their absorption profile is favored to be absorbed rapidly. Long-acting insulin will sit around in the subcutaneous tissue for 24 hours, 36 hours. And the insulin will be released slowly into the subcutaneous capillaries. Now, there are some experimental routes also, which is the inhaled or the intraperitoneal, but I will not delve into that because that's out of the scope of today. Where should we give? We should give insulin where there is maximum subcutaneous tissue. The most favored side should be abdomen. The next should be the arms, which is the tricep region, but the patient cannot themselves give it in the tricep region. If somebody else is giving them, it should be given on the arm, or they can be given on the thighs. Exercise can affect the blood flow. The depth of the injection can affect it, concentration of the dose, and insulin degradation in the subcutaneous activity. Now, how we give it is also important. Usually, the needle use should be very, very small. I'll come to how to give it. But there are insulin syringes, like, how earlier there were vials and there were syringes, and we would put the syringe into the vial, draw it, and then we would give it. That's one way. But that is going out very, very fast because the disposable, the insulin pens which are available, their cost is going down and down. And a lot of times now the cost between the delivery pens and the syringes is not much. And it's much safer to use the pens because the insulin syringes and the vials, the syringes comes in different strength, 40 IU and 100 IU. And there is a great chance of making mistake between the two concentrations. So almost always you should prefer insulin pen devices because there's very little chances of error. Try to avoid the syringe and the vial. Now, pens are disposable. That means once you finish the pen, you can throw it away like your standard ball pen. And then there are reusable devices where you can open the pen and fill in the cartridge. Yeah, think of it like an ink pen. There is also another device called the insulin pump, which is usually used in type 1 patients, in which it's like a pager-like size, and the insulin is filled in that, and that will slowly deliver the insulin to the subcutaneous tissue on a 24-hour basis. But that pump has to be worn continuously for 24 hours. So these are the insulin syringes, which you see. In our country, we use 40 IU mostly in the vials, so which is why we use the red pen. There are also 100 IU vials available. So if you draw 40 IU syringe and use a 100 IU vial, there can be a lot of mistakes. These are some older looking insulin pens. This is what the disposable pen usually looks like, and this is what the refillable pen looks like. So you would open it here, fill in the cartridge, and this is what the cartridge is. And you would attach the needle over here. This needle by manufacturer is meant to be used one time only, but practically we would use it every 3 to 4 times and then change it as a standard. This is the insulin pump. This is the oldest insulin pump available seen, and now this is the most standard, let's say a Medtronic pump, which is here. Here is where the insulin is filled, and this is delivered through this and put it on the skin. This patch needs to be changed every 4 days. Later on, you have better and better pumps. Especially the Americans are very, very pro this pump in the West, and there are fantastic pumps available. In India, unfortunately, it's not very, very popular. This is the inhaled insulin. This is the basic structure of the insulin pen. You have the cap, you have the reservoir, the needle, and the cartridge which goes inside here. And this is here where you dial the dose. When you give the insulin, don't inject it directly. You're supposed to make a pinch of fat like this, and then give it in the center over here. so that you don't inject it too deep, so that you don't inject it into the muscle. And it's also less painful to do. If you don't lift the skin, you can inject it very, very deep into the muscle. When you lift the skin, you're sure that you're injecting into subcutaneous tissue. This is where we give it. Most preferred site should be abdomen. Tell your patient, they sometimes get scared when you say, inject into your abdomen. But reassure them this is the most painless and the most effective site of injecting. Arm when somebody else is giving it, but themselves, they cannot pinch the arm and then give it. Because remember, when you're giving insulin, you have to pinch the skin. You must lift the skin. The last is thigh. And also multiple injection site. You can give it at different parts of the abdomen. Lipodystrophy is not seen much because nowadays we have very good insulins, all analogs. That was an era of the 1980s when animal insulins were given. So with this, I end my talk, and happy to take any questions.
If there are any questions, please write on the chat.
So let's see if there are. Okay. So there is one question by Dr. Sriram. How many types of diabetes mellitus are present at present, and along with type 1 and type 2? Ayurveda described more than 2 types. Collectively, college. Okay. So this is a collective question. So I'm glad you answered that question. And I think Ayurveda got it right. And thousands of years ago, it was amazing how they recognized different types of diabetes. And I'm not an expert in Ayurveda, and I've not read it, but whatever my limited knowledge of what has been described in Ayurveda is one is a person who's very, very thin and he wastes away, and that is what is type 1 diabetes. And the other type, which was described in Ayurveda, is a person who's obese and he's more lethargic, and different types of diets and therapies were advised. And this is exactly what we know now. One is a type 1 diabetes, in which the primary pathology is that the insulin beta cells have failed, mainly because of autoimmune dysfunction. The immune system has destroyed the beta cells, and they're no longer making insulin. And when there's no insulin, the person wastes away and dies without insulin therapy. And the only therapy they can use is insulin, and nowadays in some of them metformin can be used. The second type is type 2 diabetes, where in the initial 10 to 15 years, the pancreas are making generous amounts of insulin. But slowly, it's a slow decline. In type 1, it is a sudden decline right in the beginning. In type 2 diabetes, the primary pathology is the insulin resistance, mainly which has come because of genetic factors, or mainly obesity. Nowadays, we also know subtypes of type 2 diabetes, which is something which is very, very new. And the subtypes of diabetes may be thin type 2 diabetes, where in type 2 diabetes also the primary pathology is the beta cell dysfunction. Some patients may not be obese, but they may have a high degree of insulin resistance because of genetic factors. In type 2 also you have other patients where they have large amounts of insulin. In future, we'll have something called epigenetics, that we will be able to identify subtypes of type 2 diabetes and also treat them. We also know of other types of diabetes existing today, which are not type 1 and type 2. It would be wrong to call them type 3, but they are called other types of diabetes. So monogenic diabetes. Type 2 diabetes is a collection of various degrees of the genetic disorders. There's no single gene which is responsible. In monogenic diabetes, there's a single gene responsible for diabetes. Okay. And there are popular ones are MODY, MODY2, MODY2, MODY4. And in them, if you identify it correctly, like one of the MODY types of diabetes is only, they will respond only to sulfonylureas. And in them, the familial history will be under the age of 25, all the males will have diabetes. And the moment you give them sulfonylureas, they'll respond, but they will not respond to insulin or metformin or any other therapy. Other types of diabetes are gestational diabetes, which only comes during pregnancy. You have NODAT, which is post-transplant. You have steroid-induced diabetes, you have pancreatitis-induced diabetes. So they will be classified as secondary diabetes. Yeah? So you have type 1, type 2, subtypes of type 2. You have secondary diabetes, which has come up as a result of other medical conditions. You have monogenic diabetes. You have gestational diabetes. So these are the types of diabetes which we know of.
Any other questions? No. Okay. Thank you very much, Dr. Beswal. I think it was the most elaborate presentation on how to use insulin practically in the practice. Thank you very much.
Thank you very much, sir.
So our next speaker is Dr. Rahul Bakshi. He will be talking on COVID and diabetes. Since Dr. Jitesh Mehta is tired, so I will give his introduction. Dr. Rahul Bakshi is honorary consultant diabetologist at Bombay Hospital and Medical Research Center, Mumbai. After doing his MBBS from MUHS, he did MD in General Medicine from Jawaharlal Nehru Medical College, Wardha. He then completed postdoctoral fellowship in diabetes from CMC Vellore. He did diploma in internal medicine from Academy of Medicine, Singapore. He worked in the Department of Diabetes and Medicine in Alexandra Hospital and THS Hospital, Singapore for 7 years. He was assistant professor of medicine in Nair Hospital, Mumbai. He has written textbook chapters, published research internationally, and has been co-investigator in multi-centric international clinical trials. Today, he will be speaking on the most and current topic like COVID-19 and diabetes. Dr. Rahul Bakshi, please take over.
Thank you so much for the kind introduction. So I'll be speaking about diabetes and COVID-19. So let's get started without much ado. So just a little background. So December 2019, it was when we heard of pneumonia of unknown cause in a place called Wuhan. Now everybody knows this city in China. Probably before that, we wouldn't have heard about it. The causative agent was later identified as a novel coronavirus, and later, as we know it now, called as SARS-CoV-2. And the disease was known as COVID-19, which stands for Coronavirus Disease 2019. So COVID-19 by WHO. There's a close relationship between diabetes and severe viral pneumonia. Basically, there's a relation between diabetes and any pneumonia or any infection for that matter. As we understand, diabetes predisposes, uncontrolled diabetes, I should say, predisposes a patient to multiple infections. And as we have seen in the previous severe viral diseases, like in 2003, SARS, 2009, H1N1, and 2014, MERS. And on the right side, if you see this graph, so in the ICU admissions, almost 35% of patients had diabetes, whereas non-ICU, the percentage is lesser. So what this suggests is any infection or these viral pneumonias, if the patient has diabetes, he is more likely to get a complicated disease, more likely to go into ICU. And if you go to an ICU and you see the patients, probably 1/3 of them are likely to have diabetes. And in COVID, probably this percentage was even higher recently. Survival rate with or without diabetes. So this is COVID data, very recent. So what this shows the Kaplan-Meier survival curve. You can look at the hazard ratio of 3.17. So basically, if a patient has diabetes and he has COVID, he has 3 times more risk of not surviving. Or in other words, if someone who does not have diabetes is likely to survive 3 times more the COVID-19 infection compared to someone who has diabetes. So this is a very, very important number, 3 times affection of the mortality rate. And that is how diabetes is affecting COVID-19. I will just go through a few simple questions that our diabetes patients ask us. I've been seeing a lot of COVID patients since almost May. March and April, I had not started working that time, but since May, I've been working in Bombay Hospital and seeing many of the COVID patients who are admitted there. We still have COVID-19 patients in Bombay Hospital, and I've been managing most of them when they get admitted either to the ward or to the ICU. And of course, all our follow-up patients, as many of our audience would be having a lot of diabetes patients, they will ask us some questions. So let's see what those questions are and what the answer should be. So first question is diabetes patient more likely to contract COVID-19 infection? So a simple answer to this question is no. But then there are a few things which I should add on to it, that the risk is similar. Risk is same if the diabetes is well controlled, if the glucose levels are well controlled. In patients who have poorly controlled diabetes, the risk may be higher. But at present, the latest evidence, there's not much evidence to say that, but this is what is said. And of course, if a diabetes patient gets COVID-19, then everything changes. Then the risk of complications is higher and risk of ICU admission is higher in such patients. And of course, there's a patient perspective to this. I'll just add on an example. So a week back, I received a phone call from one of my patients who had last shown me in April. In fact, that was the first time when he showed me. And that time I had adjusted his insulin dose and everything. And after that, he didn't follow up. And just a week back, he called me and he said that he had collapsed and had a very bad hypoglycemia and had to be admitted to the hospital. So I went through the details. What he told me as the COVID-19 infection was increasing in the city, he himself increased the dose of his own insulin without consulting, and irrationally increased by almost 30-40% because he thought that he should keep his diabetes well controlled. His HbA1c was already good; it was less than 7, so he wanted to keep his sugar levels very tight. And in doing that, one day he had a very severe hypoglycemia and had to be taken to the hospital. So patient's perspective here, how they understand the amount of stress, because there's a lot of media coverage regarding diabetes, a lot of paper articles, social media and all that. So we need to educate our patients, that this is important. Glucose control is important, but self-adjustment like that irrationally may not be a very good idea. And here we look at this glucovigilance. So two graphs here. So who is most at risk from coronavirus? So on the left side, this blue graph, you see the age. So very simple, as the age increases, above 70 to 79 and more than 80, the risk of overall death is increasing. And here with comorbidities, so of course none will have very less: cancer, hypertension, chronic respiratory disease, diabetes, and cardiovascular disease. As we have these, the comorbidities, the risk of mortality would increase. And if you combine these two, say an elderly patient with 2 or 3 of these comorbidities, which is not uncommon, most of our diabetes patients will have hypertension, will have dyslipidemia, many of them will have cardiovascular disease. So a combination of this can be very, very dangerous. And the risk of mortality will be very high in such patients. We've been seeing patients admitted in ICU, going on the ventilator, and once the complication sets in, then it's not about COVID-19 and it's not about diabetes per se, but it's about the lung reserves and how the body responds to the infection, and then secondary infection and so on. So it can be a very, very lethal course in such patients. Another question which the patients would ask, or when we see a patient, we would like to advise them. So what should a diabetes patient do during this pandemic? The pandemic is far from over. We are seeing the resurgence in India, in some places like Delhi, and internationally also in Europe. We've seen UK is under lockdown, France, Italy again, having a lot of cases. US again, I think yesterday or day before they recorded the highest ever daily cases in the day. So it's far from over, and we still don't know what's in store for us. So how do we advise the diabetes patients? How should they, what they should be doing during this pandemic? So first of all is general recommendations, which I'm not going to too much into detail. Basically, wearing mask, personal hygiene, social distancing, using a sanitizer or washing your hands with soap often, not touching your face, and not going out, especially for, elderly patients and others at risk and others with comorbidities. And those whose sugars are not so well controlled, if there is not a necessity to move out of home, I think they should still stay home unless, it's really needed to. Then there'll be diabetes specific recommendations, which I'll come in the further slides. Regular checking if the patient is on insulin. Of course, the glucometer, as Dr. Beswal had covered in his talk regarding glucose monitoring, they should monitor their glucose regularly, and very, very important, stay in touch with your doctor. Patients should stay in touch with their doctors. Nowadays, with so much advancement in telemedicine being allowed officially by the government of India, patients should get in touch with their doctors. I won't advise, stable patients who are generally doing well to visit a healthcare facility or a hospital during this period, especially when we are working in a tertiary care center with all types of patients are visiting. Doctors themselves, when someone sees patients, we are at risk of COVID-19. So telemedicine and video consultations should be utilized. Most of the doctors are doing this now, so that should be utilized by our patients. And then, of course, this is down the list, but very, very important: lifestyle, exercise, sleep, diet, weight control, and of course, managing stress. Again, very, very important. When you speak to a patient of diabetes, some of them are so scared. You talk to them, they are very, very worried. And especially nowadays, COVID has become so common. There have been so many deaths in India. Probably each one of us knows someone who has died, a close relative or a distant one or somebody known who has, many of them have had COVID, but we know someone, I think, every one of us know someone who would have died to COVID. So the stress in such diabetes patients is very, very high. They are very, very scared from they feel that I have diabetes, and if I get COVID, it's going to be very difficult. So that stress needs to be managed as well. And it's our job to allay their anxiety, tell them the right path, that how they should approach this. So this just, I'm sharing a tweet, which if you look at the date here, which I had written, this was 25th March. So the lockdown in India started from that midnight, 12 o'clock. And this is what I wrote. So I was just going through my details yesterday when I was making my slides. So I thought of putting up a screenshot. So as soon as the lockdown started, this is what I wrote. For diabetes patients during lockdown, general activity, walking is expected to reduce significantly. Of course, we were not expected to move out, not go out for work, not even step down during that period. Make sure you plan to walk in your home for 30 to 40 minutes a day at least. Yoga, meditation. And of course, if yoga meditation, nowadays YouTube and there are so many resources, you don't need anyone to come and teach you, and learn if not doing yet. Of course, that time I used the hashtag of 21-day lockdown. I was smiling at this looking today. We didn't know that time that the lockdown was not only for 21 days, but would drag on for a few months. But yeah, it was required at that time, and it has done its job. So this is what our patients required during the lockdown, being active at home. Many of my patients say, okay, I have a terrace, I walk there. Some of them even now, they're not moving out. Some of them are elderly and they don't need to move out. They walk around in the home. They go to the terrace and walk around, because sometimes going down, you understand nowadays, the police and the government are enforcing the mask, people wearing masks, but still, the hygiene levels may not be the best. People are still spitting on in the open. Sometimes I see. So we always need to be safe with such patients who are at higher risk. What are the specific precautions for people with diabetes in terms of COVID? Of course, good glycemic control, proper nutrition, frequent glucose monitoring, SMBG, which is self-monitoring of blood glucose, should be encouraged. Many patients, who didn't have a glucometer, it's not easy for them to, every 15 days or 1 month also to go to a lab, especially even those who are not on a glucometer and only on oral agents. So I encourage them to get a glucometer, especially during this period. It's fairly cheap nowadays, and it turns out to be cost effective, and we don't need to go to a lab. So many patients are keeping a glucometer, and of course, insulin, with insulin it is necessary, but even without that also, I encourage some of my patients to get it. Regular exercise improves immunity, avoid crowded places, stabilize your cardiac and renal status. Again, other comorbidities, blood pressure, cholesterol, heart and kidney issues need to be stabilized. And high-risk patients like elderly, if it's not needed, just stay at home and stay safe. This was a news item, I think, published in Times of India 2 days back. So pandemic could trigger a tsunami of diabetes cases amongst patients. This is the same thing, like Dr. Sasank Joshi here mentioned that, the reason being same, that medical regime well exercised enough to keep sugars level in check. People became sedentary and unmindful of what they do. So this is what the lockdown has done, People have kind of become sedentary, many of them who are following, exercise and diet, they've done well. In fact, I've seen both types of patients. Some of the patients who were so busy earlier, and during lockdown, they started getting time. So they have changed their diet, they started exercising, lost their weight and improved their sugars. But some of them also, on the other hand, have, and especially with the festivals coming in, and, a lot of snacks, a lot of home food, staying at home, watching TV, movies, these things have affected weight and glucose control of some of the patients also. What could be the warning signs in our patients? So of course, COVID-19, we understand it can be asymptomatic. It can be symptomatic. I'm not going to go into the symptoms of COVID-19 per se. One important point is fluctuating glucose levels, especially in asymptomatic patients. Any infection, any occult infection, sometimes, sugar levels, if the patient is monitoring, it stays very well at a certain point. Then suddenly, without any change in diet, without change in exercise regime, patient notices that, oh, my fasting used to be 100, 110, 120. Now suddenly I'm seeing 150, 160, 180. We may have to look for any occult infection and, COVID-19. So fluctuating glucose level may be a subtle indicator here. Say if the patient has COVID-19, what next they should be doing? Patient with diabetes. Again, I'll share some of the screenshots which are, from my WhatsApp chat, which my patients have messaged. So yeah, this is not today. Basically, this was taken a few weeks back. So the patient messages me, respected sir, today an hour back, I and my husband have been tested positive. My son and maid are negative. This was rapid test. Of course, they would have done the PCR after that. And so this is, immediately the patient gets it and they get in touch with the doctor. Another one, he was detected corona positive, was asymptomatic, was in touch with the doctor they mentioned. I asked them whether it's home management only. They said yes. I told them, okay, inform me if steroids started and may affect the glucose. This patient's glucose control was quite okay. Hi, me and I think must be husband or someone tested positive. I am still getting fever intermittently. Then they ask some questions and can you please call? So immediately you can understand the concern and the worry the patient has. And here again, a daughter or son sharing about the mother diagnosed with COVID, currently in home isolation, stable. I too started getting fever from last night. Samples given, result awaited. And this is my reply here. Take care. Will cause a lot of weakness. Drink enough fluids. Monitor glucose at least twice daily. Still not on steroids. If steroids started, need to monitor more and give short duration of insulin. So basically, yeah, we'll read more about steroids and other things in the further slides. But this is what I just wanted to focus, that immediately how the patients would react when they have this and how we should be advising them. Take the rules for patients with diabetes. So just on the right side, keep hydrated, monitor your blood glucose levels, of course, temperature, and follow your healthcare team recommendation. So we may need to involve, a chest specialist or a physician or a respiratory physician in management of such cases. And of course, telemedicine is there and we should be utilizing these services. Reasons of glucose fluctuation in patients with diabetes and COVID-19. So what are the reasons here? Again, very comprehensive and important. Irregular diet, reduced exercise, GI symptoms can affect diet, resulting in glucose fluctuation. Many patients will have loss of appetite. So patient will not be eating here. So we have to watch what medicines they are on. Are the medicines causing nausea or vomiting? If yes, oral medicines we may have to stop. And at the same time, patient needs to eat well to stay, to have nourishment and hydration. So we need to guide along those lines also. Stress conditions like infections increase the glucocorticoid secretion in the body. This is a well-known fact which can affect the sugars definitely. Use of glucocorticoids in treatment can lead to a sharp rise in glucose. Very, very important point. I'm covering this in one of the further slides. There may be interruption of non-standard treatment with oral agents in isolation wards, resulting in glucose fluctuations. Fear, anxiety, and tension again may increase the glucose levels. And COVID-19 can cause human body to produce a large number of inflammatory cytokines and lead to extreme stress in some severe and critically ill patients. So these are the factors which can affect glucose levels in COVID-19. So just one slide on pathophysiology. So how COVID-19 and diabetes and other comorbidities are related, we'll just have a quick look. So diabetes has a marked inflammatory process, increased clotting factors, inhibition of fibrinolytic system, and endothelial dysfunction. Also, it leads to a development of hypercoagulable growth thrombotic state. Very, very important in such patients because one or two of the most important, sequelae or consequences of COVID-19, even after patient is COVID negative, even after patient has been discharged and is better, and which we are seeing more and more in hospitals now, I will come to that, is directly related to this in combination with the COVID-19. Of course, hypertension and cardiovascular disease, atherosclerotic, vascular inflammation, endothelial dysfunction, and old age itself has defects in T cell and B cell function and excess inflammatory markers. Now, all this in combination with COVID-19 leads to deficient control of the replication and more prolonged pro-inflammatory response, which can lead to poor outcomes. So all these comorbidities, this is how they are affecting in combination with COVID-19 and giving us poor outcomes. Endothelial dysfunction is a major determinant of COVID-19. We all have read about this, and this is directly related to the major complications which are happening, especially even after patient recovery. So hypertension, diabetes, neurological disorders, kidney disease, and thrombosis. Very, very important. We've seen a few cases. So these are all related to the endothelial dysfunction. Now we come to the steroids. Again, very, very, very important, So at one point of time, I was almost managing in Bombay Hospital 20 to 25 patients, all of them on intravenous steroids, like methylprednisolone, all of them having COVID-19. And all these, throughout these years, I've worked, seeing all the diabetes patients at various centers. I mean, at one point of time in a hospital, you'll have 4 or 5 patients on steroids, admitted for some respiratory, asthma or a neurological condition or a rheumatological condition. But this is one such period, last few months when we've had so many patients of COVID-19. Of course, steroids was the only drug and probably still the only drug which has been proven definitively to reduce the mortality in COVID-19 patients. And even after discharge, many patients are on that drug, so this is the necessity. So we affect glucose with time. So we need to see. It impairs glucose metabolism and increases insulin resistance. These are the two mechanisms by which it affects the glucose levels. And of course, these high levels in combination with the infection and dehydration can lead to DKA and HHS. So again, you look at the date here, June, 16 June. Again, I'll just share a screenshot of one of my tweets. So the gentleman said that dexamethasone, and that time, the trial result had just come out and dexamethasone was approved for use in managing COVID-19. Anyone else foresee the number of referrals for steroid-induced hyperglycemia skyrocketing? Someone better stock up on insulin and glycosides. It's just, Twitter is a random place where people will write. So just my reply, very true, already seeing about 20-25 COVID-19 patients a day with steroid-induced hyperglycemia, most with pre-existing diabetes though, and some newly diagnosed. So again, newly diagnosed diabetes were seen, probably undiagnosed earlier, or possibly, there are some reports where COVID-19 and because of the presence of ACE2 receptors in the pancreas, newly diagnosed or COVID-induced diabetes, but still more research is required to confirm that. And as I've written, high doses of subcutaneous insulin, intravenous insulin infusion, and sometimes add-on sulfonylureas is required. And at that point of time, even now in a hospital, probably our physicians and respiratory doctors prefer methylprednisolone, but dexamethasone is where the direct trial result had come, and it's still being used. In the hospital, when the patient gets admitted, what are the targets we should be looking at in our COVID-19 patients with diabetes? So target glucose can range from, this is, I'm just quoting this reference from Diabetes UK, June 2020. These numbers can vary. It may be sometimes difficult to achieve perfect glucose. And, this is just a guideline which was published, so I'm sharing it. Target glucose is 108 to 180 milligram percent and up to 216 may be acceptable. Monitor glucose at least 6 hourly before meals and bedtime, which is usually we do. Rule out HHS and DK if indicated clinically, when sugars are very high, patient is dehydrated. So we need a venous glucose, we need a bicarbonate, we need a pH and serum ketones. Insulin, of course, no doubt is the drug of choice, and intravenous insulin infusion is often required. Initially, because when sugars, I've seen the highest glucose I saw this season was around 1100 milligram percent. Of course, venous glucose, the nurses were checking on the glucometer, and for 4 to 6 hours it was coming HI high, because glucometers after a certain range, after 400, 430, stop showing the glucose levels in terms of numericals and start showing HI, which is high. So venous glucose was 1100. Patient was on intravenous insulin infusion. Still the glucose was not moving. Then of course with greater doses along with hydration, the sugars did come down. So intravenous insulin infusion has a very, very important role in such patients when they are admitted with COVID-19. They are on high dose steroids and the sugars are high. That time subcutaneous insulin probably will cease to work. And of course, patient may have DK and HHS, so these need to be checked. And then the treatment guided accordingly. Hydration, again, looking at the renal function, looking at the cardiac function, normal saline or appropriate fluid hydration will be very, very important in such cases. We'll discuss about the oral agents one by one, because many of our patients are on oral drugs already. There is a tendency when a patient gets admitted, initially when the junior doctor sees or when the patient is seen by the doctors, there's a tendency to just continue what the patient was on. But this can be important in these cases because many of them will have dehydration, may have affected renal disease. We've had a lot of acute kidney injuries in such patients, sometimes dehydration induced, sometimes existing, sometimes drug induced, during the admission. So it's very important to go through the patient's drug list and then, probably stop whatever is not safe at that point of time. Metformin, commonly used drugs. Almost all are type 2 diabetes patients with normal renal function and without any organ failure would be on it. But this, in an ill patient, in a patient who's admitted, I prefer to stop initially. Risk of acidosis is high. Even though lactic acidosis is rare, patient already has a respiratory disease, and because the fact that they have got admitted, they probably are expected to have or already have some respiratory compromise, or they have comorbidities and some other complications going on. Risk of acidosis will be high in such patients. So I'll usually stop it on admission. Another reason of stopping is, this drug, of course, causes nausea, vomiting, sometimes diarrhea. In such patients, they will have loss of appetite already. So I don't want to complicate that. And of course, creatinine needs to be monitored, which of course is done. But then, even slight rise in creatinine, which is very, very common in such patients. Acute kidney injury was very common. Our nephrologists were so busy rounding, every day I used to meet them in the COVID wards in PPE. So, and many of our patients did require dialysis also for that matter during that period. So it's important that we go through the drugs on admission, and whatever drug can harm the patient needs to be stopped for that time. DPP-4 inhibitors, many of them available. Generally, they are well tolerated. Depending if the patient is taking orally well, I usually used to continue this. And metformin also, as I've said, I stopped on admission. But as the condition improved, renal function stabilized, patient starts improving, starts taking orally well, I would be adding these drugs back again very soon. Once the patient is stable, because it helps in glucose control a lot, because only with insulin also steroid-induced hyperglycemia was and is very difficult to manage. So I would be very keen to restart this once I feel that patient's appetite is good, renal function is stable, and started taking orally, and the respiratory condition, when they are on low concentration of oxygen or off O2, when these factors are there, risk of acidosis is lower, I would be restarting these drugs. Sulfonylureas, initially, usually I will stop depending on the glucose levels, but I was going to the guidelines. So many guidelines say that sulfonylurea do not have a good role in COVID-19 patients. So I slightly differ on this, based on my experience over the past few months, because why they mention this is they probably, are worried about because these are insulin secretagogues. So they feel that the pancreas may already be overworked because of the higher glucose levels, and this may not help. But I've been using sulfonylureas, glyphosate quite often in almost all my patients, along with insulin in such cases, and I have got fairly good results in such patients. So I've been using this depending on the renal function, age, and the glucose levels. SGLT2 inhibitors, the newer drugs, again, very common. I mean, the use of these drugs has been increasing gradually, especially because they are of the cardiac benefits and their effect on weight. But again, I'll just share a tweet here and we learn from here. So this I wrote on April 19th April. So there was some guideline which mentioned that SGLT2 inhibitors should be stopped in all patients admitted to the hospital. That's again very, very important, because it's not that the patient was on a drug, just continue old medications, CT-all, or just continue own medication, home medication. There is a tendency to do that, but there should be a reason to do that. We should go through each and every drug the patient is admitted with and then decide whether it's needed or not. So here, what is the reason to stop SGLT2 inhibitors in our admitted COVID-19 or any admitted patients for that matter? Euglycemic DKA. Euglycemic, which means normal glucose levels, diabetic ketoacidosis. That is, DKA with normal glucose levels is a known side effect of SGLT2 inhibitor. Is not very common, but we have seen cases, and it should be stopped rightly in any sick patient, including COVID-19, those who have dehydration or risk of dehydration also in the perioperative period. So any patient who gets admitted to the hospital, with an infection or with a cardiac event or with a vascular event, I usually will stop this group of drugs. There is no acute benefit, to continue it during that period. And of course, these are excellent group of drugs. I use them very often, wherever possible, but the timing has to be correct. So in an admitted patient in COVID-19 and otherwise, it's important to stop this group of drugs. These are the drugs like dapagliflozin, empagliflozin, and the others. A few more oral agents, alpha glucosidase inhibitors, acarbose, voclibose. These are the drugs which are also quite common, more common actually in India than other places that I've worked with. And reason being, the triple drug combination and double drug combination are very commonly used in India compared to some of the other countries. So because of those combinations, we have these like metformin along with the sulfonylurea and along with voclibose. So like GMV. So there are a lot of combinations, maybe 50, 100 combinations which will be available in this group of drugs. But this drug does cause, as we know, the common side effect is flatulence. And, sometimes they can cause a lot of gastric disturbances. And initially, I'll probably stop it in an admitted patient for the reasons mentioned, similar to metformin. Thiazolidinedione, not commonly used outside of India. Still the usage is very, very high, especially in the older patients. I don't use it very often. And here again, because of its propensity to cause fluid retention, and we understand, some of our patients may be in respiratory failure, may have pulmonary edema and so on. So I would usually stop this in our admitted patients. And then once the patient improves, if the patient was already on this drug, this is still a very, very good drug in patients with insulin resistance. No mistake. So, I would probably restart it later once the patient is better compared to an admitted patient. target stratification of glucose management. So of course, the glucose targets cannot be the same in all our patients with COVID-19. We have to stratify, we have to look at the age, the comorbidities, the condition at that point of time, and then aim for a particular glucose level. I cannot just have, say, aim for a fasting glucose level of 95 to 110 in all my patients. So for mild and moderate, non-elderly COVID-19 patients, stick to strict high control targets, yes. So for mild to moderate elderly or patients who have been on steroids, set up a lower medium control target. And for severe and critical ill patients, elderly patients, or hypoglycemia intolerable patients, very, very important. Hypoglycemia is common in such patients, especially when we give such high doses of insulin. So even subcutaneous insulin, I've ended up giving 100, 110, 120, 150 units per day. Combining a basal and bolus. If I total up the per day dosage, I have gone up to 150. Some patients even 200 units per day. Along with intravenous insulin at some point of time. So it's very important to decide what type of targets we are aiming at, to inform the patient and also inform the treating consultant or the team also that this is what we are trying to do. Because sometimes when the patient sees a single glucose of 300 in the ward, he will get very worried. Already has COVID-19, say has a cardiac issue, the nurse is checking before lunch glucose or evening glucose. Steroid classically causes lunchtime and evening time high glucose. Morning glucose is usually okay. So morning would be 70, 80, 90, 100, at that range. And suddenly before lunch or evening glucose would be 300. So we have to, speak to the patient, work on the dose titration, but patients should be, if you take the patient into confidence, half their problem is over, because the anxiety is very important to be handled. So, we should let them know how the steroid affects the sugars and then, set expectations depending on the comorbidities and other things. Hypoglycemia occurrence should be minimized during glucose management in diabetes patients with COVID-19. It's a very, very important statement. Hypoglycemia can become very common when we are using, very high doses of insulin 3 to 4 times a day. So close monitoring, sometimes, even 5 to 6 times a day, we have to monitor this. So I'm talking about subcutaneous insulin. Intravenous insulin will be, of course, hourly monitoring, or, sometimes 90 minutes once the patient stabilizes. But here, 3 to 4 times a day, and sometimes even more, we will monitor and always look out for hypoglycemia and explain to the patient what are the symptoms of hypoglycemia, what they should be doing when it happens. Keep some sugar or some sweet stuff next to the bed. So if it happens, they can call the nurses, get the sugar checked immediately, and then act on it. So 10% of the patients suffer at least one episode of hypoglycemia during this period. Hypoglycemia has been shown why it's important. It's a very scary episode. Hypoglycemia, when you ask a patient how they feel, hello, you can hear me? Sorry. Yeah. So those patients who do not experience, those of us who have never experienced hypoglycemia, it's very difficult when the patient says, that sometimes it's a feeling like they're going to die. That is what hypoglycemia can do. So we need to be very careful about that. How to handle hypoglycemia during the lockdown period. So this is for the patients who are at home. If you experience blood glucose level, I always ask them to check and then eat glucose tablets or another high sugar snack. Measure the glucose if possible and rest. Always keep some glucose tablets or high sugar snacks. And if symptoms have disappeared, of course, get in touch with your doctor, and then treatment may be modified. Reason may be needed to find out, was it a one-off episode or what's happening there. Sorry. Consultation through telemedicine, I have mentioned that this is now available, and all patients should take advantage, with their respective doctors of this facility. Post-COVID management. So once the patient is treated, goes home, what next? Watch for complications. We've seen many patients again, getting admitted in a hospital, getting treated with COVID, and now they're admitted. I've personally seen in Bombay Hospital with, either some cardiovascular complication or a pulmonary thromboembolism or a DVT. So this is the thrombosis and the pathophysiology which I was talking about. So very, very common. So patients still need to watch it. Many of the patients are being given antiplatelets, and other drugs just to minimize the risk. Many patients here, it's important to understand, may be on insulin for the first time. So COVID-19, even patients have HbA1c of 6.5 or 7. They are doing well. But when they are started on high dose steroids, sugars shoot up, and I put them on insulin. And sometimes even on discharge, when they are decided to be continued on steroids, I may need to give them insulin for a short period. So that is their first time with insulin. So talking to them, telling them that why we are doing this and we'll be able to stop insulin soon will allay their anxiety. And and once the patient has confidence, we get good results. And once the steroids are tapered, the sugars will improve and we are able to stop insulin in most of them. post COVID, there's loss of appetite, generalized weakness lasting for a couple of months, which many of my patients say, and weight loss, very, very important. I've seen patients losing weight, and I'm sure many of you who've been seeing COVID patients for months and following them up have lost weight from say 4 kgs to up to 12 kgs, within a week or two of COVID-19. So this is the weight loss many of our patients are having. And this is what we need to understand to explain them. And some of them who are already on the higher side, I advise them, okay, this has happened. But now we can, of course, the weight will come back, some of it. But then, they can take this and try and maintain their weight to a healthier one if it was not already. Gradual resumption of activity, once they start feeling better, start walking and around, will help also. So in summary, COVID-19 and the lockdown has had a huge impact on our diabetes patients. Awareness and education amongst patients is very, very important. Those who are at home, you need to get in touch with their doctors, and then, we should guide them. Diet and lifestyle measures are very, very important, along with, walking, healthy diet, and yoga and meditation has a very important role to play. And steroids can play havoc with glucose, and close monitoring and follow-up is required. This is the last slide. Thank you.
Just try and answer whatever.
Yes, sir. Let me just. Yes, sir, I can see. Okay, I will start with one question from Dr. Shobha Kamath. Dr. Bakshi, what is the maximum level of HbA1c? The question is, what is the maximum? Yes, sir. What is the maximum level of HbA1c to say the patient is non-diabetic? Is the fluctuating fasting sugar of 100 to 130 and PP of 120 to 150 who is having high risk of hereditary, whether to start treatment? Okay, this question is not directly related to COVID-19, but I will answer this. So, okay, maximum level of HbA1c to say the patient is non-diabetic. So how HbA1c is classified by American Diabetic Association? I will just simply answer this. So HbA1c less than 5.7 is normal. 5.7 to 6.4 is pre-diabetes. 6.5 and above is classified as diabetes. But in the Indian context, there are not a lot of Indian studies done on this. So what I always do initially, when I diagnose the patient for the first time, we will not only go by HbA1c alone. So it's important to do the HbA1c, do the fasting glucose, and do the postprandial glucose. Or in some patients, I will prefer the oral glucose tolerance test. So HbA1c, I've told you, less than 5.7, 5.7 to 6.4, and 6.5 and above. For fasting, the similar levels are less than 100 is normal, 100 to 125 is impaired fasting, 126 and above means 126 fasting is diabetes, and above is diabetes, this is fasting. And for postprandial glucose, the similar numbers are less than 139. 139 and below is normal. 140 to 199 is impaired glucose tolerance, IGT, and 200 and above after food or after sugar load, is diabetes. So this is the answer for Dr. Shobha Kamath. Second question, Dr. Shalu Bhutani. Hyperglycemia in non-diabetic COVID-19 case. Yeah. So again, this is very, very important, and I think I touched upon that. So, so not all of our patients will have pre-existing diabetes, or even, when they get admitted, HbA1c may be 5.5. But when the sugars are checked, because they have COVID-19, because they are started on steroids, they will have very high sugar levels, 200, 300, and so on. So that is what hyperglycemia in a non-diabetic COVID-19 case is. So there I will be managing them in the same manner which I told you. Initially insulin, if required, infusion, and once the steroids are off, that's when we can modify the treatment. And many a times with diet and lifestyle, later on, once the steroids are off, patient can come off medication. So the such patients, it's important what we write on the discharge summary. They are not diabetes patients. There I would mention steroid-induced hyperglycemia, or steroid-induced and something similar. So that because once the label of diabetes comes on a discharge summary, even for medical legal purposes, that can have an important say. So it's important to check what we are labeling the patient as. Next question, among oral hypoglycemic agents and insulin, which one is preferable overall? So there's no clear answer to this. This is by Dr. Nair, of course. I have already mentioned about, we are talking about COVID-19, so we'll stick to what we are speaking. It's very difficult to answer this in short. So depending on the patient, and I think Dr. Beswal covered this part earlier, that when is insulin more preferable in patients? So I think that is the right thing to do. This may not be, answerable at this point of time. Okay, another question just now. What is the target BSL fasting and PP for severe COVID-19 patients on high dose steroids? So the guidelines mentioned, the guidelines are very clear in this. So the fasting levels say anywhere around 90, 95, 100, in that range 100 to 120, and at postprandial levels. So that was the fasting, and postprandial, anywhere around maximum I will tell you is 180 to 216. This is what the guidelines say. But trust me, it's not so easy when patient is on high dose steroids to achieve those targets. So we try our best, because at one side I have to make sure the glucose doesn't shoot up to 300, 400, and at the same time I have to make sure patient doesn't have a severe hypoglycemia. Because it's very easy to give 10 or 20 or 30 units of short-acting insulin like Actrapid or Novorapid. But single dose can cause hypoglycemia. Hypoglycemia can bring a patient from home to the hospital if it is severe. So we have to take that into account. So sometimes, and depending on the comorbidities, I showed the stratification. If the patient is elderly, patient has renal disease, I rather have a sugar of 200 to 250 postprandial in some of my patients for a short duration, for a week or so. Because fasting sugar, as I told you, on steroids will be quite okay. It's the postprandial which will be an issue. So we have to, depending on stratification, decide the steroid management is very difficult. Sugar management in steroid patient can be very difficult.
Thank you, Dr. Bakshi, for elaborate presentation of the.
Okay, there are some questions. Some of them are very generic ones. I'm just trying to pick up something relevant to today's talk. Sure, thank you, sir. Thank you.
Thank you very much
Thank
for
you.
the current and hottest topic and answering all the valuable questions. Thank you very much. Now we will have a short video on DigiShield. Hello?
Yes, sir. Thank you for the opportunity.
Thank you,
So
sir. Thank you.
DigiShield is an app made for the doctors to record the data of the patients and history. Will not take you much time. We'll just play the video.
Download the DigiShield app from the Play Store or App Store now. New users will go through a quick one-time registration process. After filling in some basic information, registration is complete and you can start using DigiShield. Logging into DigiShield is easy, safe and secure. Enter your registered mobile number. An OTP is sent to your mobile. Enter the OTP and you are logged in. No passwords to forget. Making a patient's appointment is easy. Just click on the calendar sign, enter the patient's name and mobile number. Select date and time of the appointment and that's it. A confirmation message will be sent to the patient and so will a reminder. A day before the appointment, your patient will be automatically contacted by the DigiShield agent. The Shield agent will collect the patient's symptoms, history of present illness and more. The agent will also collect any consents or indemnity that you want to collect from them. Based on the DigiShield interaction, you will be alerted to the patient corona carrier risk. It's easy to do a phone or a video consultation with the patient. DigiShield recommends that patients that have been flagged with a high or moderate corona carrier risk should be consulted via consultation first. Click on the phone icon or the video icon to do a safe and secure teleconsultation with the patient. In order to issue an e-prescription to a patient, tap on the pencil icon, tap on the camera icon to take a photo of the prescription and you're all set. The prescription is sent securely to the patient immediately. DigiShield is easy to use and you will be online within 5 minutes of downloading the app. Download DigiShield on the Android Play Store or Apple App Store today. Protect yourself, your patients, your community. Download DigiShield for free today.
So DigiShield is available free on Apple as well as Android Play Store, and it's free to use as well. Thank you, sir.
Thank you very much. And now we will have the last speaker formality by vote of thanks by Dr. Sachin Patharkar. Dr. Sachin Patharkar, please.
Good afternoon, everyone. I would like to thank our speakers of the today's webinar, Dr. Mangesh Patil, Dr. Bipin Chandra Bhamre, Dr. Viraj Vilas Nevrekar, Dr. Gaurav Beswal, Dr. Rahul Bakshi. I also thank our knowledge partners for the day, Sir H.N. Reliance Foundation Hospital, Intas Pharmaceutical Private Limited, USV Limited, and Dr. Gaurav Beswal
Mr. Dipen Mehta and Mr. Chirag from DigiShield, who have given us the platform for this webinar and handle all technical details. At the same time, I also thank our observer, that is MMC observer, Dr. Anil Awad, and all the delegates who had participated in large numbers to make this webinar a grand success. Thank you all. Have a good day. Thank you very much.